ब्रह्माच्युतशङ्करप्रभृतिभिः देवैः सदा वन्दिता सा मां पातु सरस्वती भगवती निःशेषजाड्यापहा। शुक्लां ब्रह्मविचारसारपरमाम् आद्यां जगद्व्यापिनीं वीणापुस्तकधारिणीम् अभयदाम् जाड्यान्धकारापहाम्। हस्ते स्फाटिकमालिकां विदधतीं पद्मासने संस्थितां वन्दे
check this one check. ये दोनों छोड़ के सर्विस, ये दोनों छोड़ के दूसरा माइक हो दोनों. check this one check, check this one check.
accrediting this program and providing credit points for all our participants in this event. On behalf of IMA, I would request Dr. Nilesh Talwardkar, President of IMA Tiswadi, to come on stage. I would like to felicitate him. So we begin our sessions. This is a miscellaneous session first, wherein to chair this session we have Dr. Sandeep Patel. Dr. Sandeep Patel is a young, energetic orthopedic surgeon from BGI Chandigarh. He has clinical interest in orthobiologics, pelvis and acidovular fracture, foot and ankle, complex trauma and arthroplasty. He has to his name 150 publications in index journals and more than 1,500 citations with an index of 15. He has been invited as speaker for various national and international conferences. He has conducted multiple workshops on PRP and orthobiologics. Dr. Patel has 2 patents to his credit. I welcome Dr. Patel and take forward the proceedings.
Yeah, good morning, everyone. So the first session is basically a mixture of a lot of interesting burning topics. So for the first talk, I would want to call upon Christiana. Yeah, and she'll be talking on early weight bearing. So we've seen a lot of things change over the past decade, from immobilization for a long time to early weight bearing. So I think she'll be touching upon the relevant aspects of it.
All right. Good morning, everybody. I was assigned some of these topics. I didn't choose these, so some of them I sort of interpreted. And because I can't read, I read this as early weight bearing, is it time, instead of it is time. So there's a question mark. We're going to go through that. I'm not sure if I have any answers for you. There's a trend towards earlier weight bearing in many injuries. I think it's understood by all of us, or it's common sense, that elderly patients cannot mobilize without weight bearing. And so what we really need to figure out, I think, as we go forward is which injuries can bear weight safely, and maybe more importantly, which patients can bear weight safely. And do we really have any control at all over what our patients do? Some days in clinic, I'm certainly convinced I have no control at all over what my patients are doing. And so let's do a quick audience poll, just to make sure everybody's awake this morning. Would you restrict weight bearing post-operatively in these patients? So let's do a show of hands. Periprosthetic femur fracture that you have fixed in a 71-year-old. Who's restricting weight bearing? Maybe like a third of people? Okay. And then a healthy 17-year-old male with a pretty simple posterior wall that you have fixed. Who's restricting weight bearing? Yeah, not as many as I thought, maybe half of you. What about a 75-year-old with a distal 1/3 extra-articular tibia that you have fixed? You fixed a little bit short, so you have a little bit of bony contact. Who's restricting weight bearing? Dr. Wickstead, who said he just lets everybody walk yesterday, is currently restricted all 3 of these patients. So I think he just doesn't like my x-rays. Another one, we have a 25-year-old healthy person, isolated syndesmosis injury, so ligament-only injury with 2 screws. Who's restricting weight bearing for that person? Everybody. I feel like this lecture's over. We just restricted all of our weight bearing. So there's some controversy, right? So you guys can't see yourselves, but when I look out at you, there's, at any given moment, 50% of the crowd is doing something different to the other half of the crowd. And so people, even among experts here, we vary in what we would do for each of these patients. And I'll tell you that of the 4 that I just showed, 2 of them I let weight bear completely immediately with no restrictions, and 2 of them I did not. So what do we have in the literature that can help us? What can guide us in terms of these decisions? And I think a lot of the talk really started first in about 2014 when this was presented at the OTA, but in 2016 when this paper came out talking about early weight bearing in ankle fractures. And I think this is something that caused a lot of us to at least start thinking about or talking about progressing the weight bearing earlier in some of the simple and most common fractures. And so this paper was out of Canada, multiple different centers, and they looked at ankle fractures and early weight bearing versus staying immobile for 6 weeks. So they really looked at early weight bearing as well as early range of motion. But basically they found that the early weight bearing or early mobilization group did better, and that there really weren't any wound complications associated with moving people early or starting them weight bearing early. But I think one thing that's happened over time is that this study has been extrapolated to include all ankle fractures of all varieties. Whereas they were very specific in their inclusion and exclusion criteria, right? They didn't include anybody in the study who had a syndesmosis injury or who had a posterior mal that needed to be fixed, and they didn't do any severe open fractures, so no type 3 open fractures were in the study. So they did sort of ankle fracture light, I would argue. And ankle fracture light did great with early weight bearing, but maybe not all ankle fractures. And so similar study, but looking at different trials in a retrospective study. And what they found actually was that there were higher complications in the early mobilization group. So usually like wound complications or fixation failure. And then we started talking a little bit more about distal femur. I would argue is the next big topic people have really looked at is how does the distal femur respond to early weight bearing? And so this is 51 patients with a mean age of 64. They're all treated with a locking plate, and this is out of Britain. And basically what they were looking to see is if group A that had non-weight bearing or touchdown weight bearing, how did they compare to no restrictions at all? And so there were no differences in the two groups statistically. There were no postoperative complications in the early weight-bearing group, but what they actually found was a higher rate of fixation failure in the late weight-bearing group. And they assumed, or they thought that that may be because there's delayed healing when you're not weight-bearing, and that actually causes the fixation failure. And this was a non-randomized study. And then this paper is actually out of our group from Arizona looking at just the biomechanics of periprosthetic femur fractures when you're bearing weight early. And so they sort of summarize the literature that there's limited data out there, but it does seem like there is mechanical data that suggests dual implants, so either 2 plates or a nail and a plate, allow enough support for physiologic weight-bearing loads. So we have some evidence out there, but I would say not a wealth of evidence to support early weight-bearing, but we certainly have good reasons to want patients to weight-bear. So I have 3 cases I want to go over with you today. The 3 cases I've sort of summarized here. One of them we said weight-bearing is tolerated, but they didn't, and it was not fine. One of them we said limited weight-bearing, but they didn't, and it was fine. And then one of them we said limited weight bearing, but they didn't, and it was not fine. So let's just talk a little bit about each of those. So this is a 91-year-old female, status post-fall, very osteoporotic, extra-articular distal femur fracture below a total hip. And so when we were deciding what to do with this, we kind of looked at these different options and decided that the number 1 goal was early mobilization, and so chose to do a nail plate construct, which I think you could definitely argue is a lot. But the whole goal, I think, behind this was to get this 91-year-old patient up and moving very quickly. So we immediately made the patient weight-bearing as tolerated, encouraged her to get up and around. And at 2 weeks, she came back, and then at 4 months, she came back, a couple of visits in between. But essentially, we had made her weight-bearing. She came back and said she had no pain, but she was too scared to bear weight. She was worried. She didn't want her break to fall apart. So she had spent 4 months not putting any weight on this. So her family brought her into the clinic in a wheelchair, which seems bad. And you can actually see on here, it doesn't look crazy, but if you look on the lateral view, she really doesn't have much healing to speak of at all between 2 weeks and 4 months. And then what we did at that point is really talk to her and her family, get her into physical therapy, really try to make her weight bear. And she did progress to make more bone with weight bearing. And so for this construct in particular, what I find is I don't think these nail plate combos, or sometimes even dual plate combos, I don't think they heal unless the patients are weight-bearing. I think you really have to get them weight-bearing, otherwise you make a construct that is too stiff, and they really don't progress at all. So I will only do this now in someone that I know is going to get up right away, and I will really come after them with a cattle prod to make sure that they are getting up right away. So there's one example. And so that was, we said to weight bear, but she didn't. And we talked about sort of what that implications of that were. This is a different gentleman, 76-year-old minimally displaced acetabulum. It's not just a wall, it does go through the posterior column. And so I had said, let's do touchdown weight bearing for 6 weeks so we don't cause any displacement. Your fracture's in a great place. He then missed his first follow-up appointment and then came back at 8 weeks, no pain, walking with no assist, just walks into my clinic, no cane, no nothing. And his wife says he's been doing that since literally the first week after his injury. So he never protected his weight bearing at any point. And he actually healed fine. He has a little tiny bit of deformity, I think, through the posterior column, but overall his joint is well maintained and he is doing great. He honestly didn't care what we had to say. So he was told to restrict weight bearing, didn't, and he was great. So the patient in that case knew better than we did. And then this is a different case. So 67-year-old, obese, bad diabetes, poorly controlled, neuropathic bilateral lower extremity, open distal tibia fracture. So for me, this is just a bad day. Really a nightmare injury that's difficult to manage. I don't think there's really a great answer for this. This is actually, that yellow line is the distal extent of the fracture, so we have almost nowhere to put hardware, and we have a huge anterior medial wound. And so circling back to something that was said yesterday, which I really liked, so I added to this talk, was twice, for diabetic neuropathic patients, twice the fixation, twice the immobilization, twice the time to weight bear. And that was my plan for her, actually. And so this is what I did. This is a little unorthodox, but I think it's sort of beefing up the fixation, and I tend to use this nail in neuropathic diabetic patients not infrequently. And so she was in a cast, so more immobilization. She had a window for wound care, and we had her strict non-weight bearing. So at 6-week follow-up, her wound had healed. The bottom of the cast, though, was completely worn through, and she says she has not been weight bearing, but on the way to x-ray, she was just walking down the hallway, and this is what happened, and I have literally never seen this happen before or since. She just pulled the entire nail out of her hind foot. She has nothing in the talus, nothing in the calc. And I was pretty impressed with that, I have to say. So in this case, we said to restrict weight bearing, and she didn't, and it was not fine. It ended poorly. But that's probably because she didn't have a pain sensation, so she didn't really have a way to limit herself. And she also had no way to really tell how much weight she was putting through the leg. So in summary, common sense tells us that patients would benefit from early weight bearing. The literature shows that some fractures or fixation constructs can allow early weight bearing and that that's safe. It's unclear, however, if early weight bearing is safe for all or many different injuries. And I would just say, for me, it's a big caution. Anybody who can't tell if they're weight bearing or doesn't have enough control over their actions to protect their weight bearing, you have to be very careful with. So someone who has bad neuropathy, bad obesity, so very bad balance, and then drug and alcohol use. And a lot of my patients, unfortunately, have all three of those together. So I think you have to be very careful with early weight bearing in that set of people. This is what she ended up with, in case you're curious.
Yeah, so we can have a quick question before Dr. Golden comes in for his next talk on compartment syndrome.
All right, thanks again. So we're going to talk about compartment syndrome, which is, when I saw that this was going to be one of the topics, on the surface, all of us have heard about compartment syndrome sort of since we started orthopedics. I was like, well, is there going to be a whole lot to talk about? We all kind of know what it is, but hopefully at the end of this we'll figure out that maybe we don't know what it is and we don't know who we're treating and we're just kind of doing it because everybody told us to do this. So just as a quick review, what is compartment syndrome? I think we all know this. Critical pressure rise within a confined space results in some decrease in the blood supply, decrease in perfusion pressure, End result being ischemic contracture, muscle necrosis. This was first described by Volkmann as a Volkmann contracture. This was way back in 1881. At that point, he was just talking about forearms and hands. Hildebrand in 1906 then expanded that so that it's still talking about Volkmann contractures, but using it in other parts of the body and any kind of compartment syndrome. We're all pretty familiar with the consequences if you miss them. Muscle necrosis, infection, non-union, bad things happen. In the US, I don't know how much this is a problem in India, but in the US, the legal aspect of compartment syndrome is huge. This was a study that just showed that the average payout on one of these was $426,000. If you compare that to the average payout on other orthopedic cases that were lost, those were $136,000. So you can see it much higher. And this was way back. Study was from like 2004 or so. So these numbers would probably be much higher. And a higher percentage of the claims were successful. The interesting thing that came out of this from a clinical standpoint is that anybody who had been released within 8 hours, all those cases were won for the doctor. So really pointing out that time to diagnosis and compartment release is really sort of the critical thing with this. The problem is, do we really know who gets this? And this is the part where I think it's kind of more interesting. If you look at all the studies that are done on this, the way we define a compartment syndrome is the person had a fasciotomy. So that's completely circular, right? We're defining the disease that we're trying to measure based on we thought they had the disease, so we did something about it. Almost none of them point out, after they had the release, did they actually have a compartment syndrome? That's really hard to figure out. How do you know if somebody's had a release if they had a compartment syndrome, unless all the muscle's already dead? In which case, then you missed a compartment syndrome, which again, if you go back to the legal aspects of this, most people aren't going to be super excited to report a big series of all these compartment syndromes they missed from legal and professional matters. So there's not really a gold standard for how we diagnose this, because if you do a study and you release them, you define that they had it, so then whatever criteria you used to determine to release it is right. So we really have no idea. If you try to do a randomized control study with this, it's kind of hard from an ethical standpoint, because you can't really have a control group where you decide not to release them, since we all know that bad things happen. So it's kind of akin, this was a case that was for the US Supreme Court back in 1964, where they were trying to define what's pornography. And part of the case hinged on what the definition was, and a famous quote that came out of this was from this justice that says, "I can't define it, but I know it when I see it." And that's sort of where we are with compartment syndrome. We all kind of know what it is, and we kind of release it when we think it is, but it's tough to prove that that's what it is. Oh, I don't think the little clicker is working. Oh. Can you advance it from there, or you can whack it a couple times? Oh, there it goes. So if we don't know what it is, then it's helpful to know who the people are who are going to get it, because then we can help predict that. Leg and forearms are the most common. Men tend to get it much more frequently than women. Younger age people tend to get it much more frequently than older age people. The hypothesis with this maybe is because you lose muscle mass. So if you're young and you have an increased bulk and you have some swelling, there's less room in the compartment for anything to swell. It might also be that older patients tend to have hypertension, so they can tolerate a higher raise in pressure because their overall perfusion pressure is higher. 2/3 of the people who get it have had a fracture. Tibial diaphysis fractures are responsible for a large percentage of them, with any ranging anywhere from 2.5% to 15%, depending on which study you look at. Tibial plateau fractures in some studies have also been shown to be pretty high, and as we said, the forearm fractures. An important thing is they can occur with high or low energy. It doesn't have to only be high energy fractures, and a lot of the studies, if you look at which cases they came through, less than half of them are really high energy. A lot of them are fairly low energy fractures. And they can occur in open and closed. A lot of people say, well, if it's open, it's auto-fasciotomized. That turns out not to be the case. And some people with low Gustio-Anderson classifications may have higher risks of compartment because it was a high enough energy to cause a lot of damage, but not enough to really rip everything open. This was a guy who ended up developing one. He was 25 years old, motorcycle versus truck. He had that plus a plateau. He was actually taken to the OR by one of my partners for an X-fix, and by the morning had developed a compartment syndrome. So I ended up releasing both his thigh as well as his leg. Special case of this, I'm at a facility that treats a lot of gunshot wounds, so we're always looking for stuff on that as well. If you look at people with gunshot wounds, this is in forearms, 46% of those had fractures in this series. A lot of them had other gunshot wounds, and 10% of them developed a compartment syndrome. The more interesting thing with this is that the ones that did, most of them are proximal, so sort of near the elbow joint. There's a much higher risk than not near the elbow joint. Also to point out on this, that 6% of the people who got compartment syndromes did not have a fracture. So just because they don't have it, you still need to look for this. Another study that looked at ballistic fractures sort of in more places than just the forearms had pretty similar findings. About 3% had compartment syndromes, but again, proximal tibia and proximal fibula, so again, near a joint, had higher a risk. And those with vascular injuries had them more as well. So this was another guy, he was another gunshot wound, had a SFA injury, and he was taken to the OR with vascular by us in the middle of the night, released his thigh, released his leg compartments prophylactically after they did because they were doing a revascularization, was put into an X-fix and then eventually nailed. Here's 4 months out. He's not forming a whole lot. And that's been shown on a lot of these people with compartment syndromes that maybe they have a delay to union. You can also see the big graft sitting right here that they had put in for his injury. So I think I've seen a couple of these where they put these tube grafts in and it's slow to heal right near where the fracture is because of that. I can't prove that, but I've got a bunch of them that seem to show that. But 8 months he had healed. But you'd think in a 17-year-old he should heal the femur fracture much quicker. So how do we diagnose them? Typically we would talk about swelling, all the P's that everybody talks about. A couple of them you notice I left out, the pulselessness and the pallor that everybody talks about, because that's a very late sign. So if you're waiting till that develops, you've already kind of missed the boat. So the big ones that you could do something about would be the swelling, pain on passage stretch, and pain out of proportion. The problem with these is they're super subjective, right? Many patients have different pain tolerances. You have patients who don't have any pain with some of this stuff, and patients who have tons of pain no matter what you do. So that's not a really great thing to look at. McQueen tried to look at this, and if you see how, here's the main ones that we all talk about, pain on passage stretch and whatever, they're really not good. So the negative predictive value of these is terrible, or the positive predictive value is terrible. The negative's okay. But right, the sensitivity is terrible on all of these. So we use these constellation of findings, but they're not really very good for this. She did find that the intercompartmental pressure monitoring, at least in their series, was pretty good. So maybe we should measure lots of them. But then the question comes up, well, how do you measure them? Do you do a single measurement? Do you continuous measurement? And where should you measurement? In the US, I would say this is pretty much what most people do, what's called the Stryker needle, although Stryker doesn't own this anymore, so I guess we'll have to figure out whatever the new company is that took over the patent on it. But, the single pressure monitor, and you've got your little syringe, and you hook it up to the little pressure monitor here and the slit needle, and you stick it in and see where you are. There's lots of problems with this, and a lot of people believe you can kind of make the thing read whatever you want it to read, depending on how much fluid you push in, where you put it in the compartment, that sort of thing. This was looked at if we do a single measurement and a one-time reading, using a delta P of less than 30 millimeters of mercury as your key, and they found a false positive rate of 35%. So you're kind of just rolling the dice if you do a single measurement on these. What if you do a continuous measurement? This was the Edinburgh protocol. So they do continuous monitoring. So over a 2-hour period, they watch it. And the important thing with this, which kind of gets lost in some of it, is that they look for trends. So if you have a single measurement over that 2 hours that's less than 30, that's okay if the trend is still coming down. And they thought that might decrease the risk, the time to fasciotomy, but it did not increase the rate of fasciotomies. So that would be a pretty decent test. The problem with that is it's pretty labor intensive because you have to have nurses or physicians watching this all the time, and you have to have a system where you can do it. Where do you measure it? Is it supposed to be within 5 centimeters of fracture? That's typically what's kind of said. But some people say, well, then you're putting it right where the hematoma is, and maybe that artificially elevates the pressure, and maybe the rest of the compartment doesn't need that. So again, we're not really sure. If you're using the single ones or the continuous one, you got to make sure your transducer's at the same level, because you can change the pressure depending on where you put your pressure monitor. So that's a problem as well. If you're only going to do one measurement, where should you do? Well, if you're doing the leg, most people say the anterior compartment, which would be up here, because it's the most commonly affected. But ideally, you should do multiple ones if you're really worried. Same thing with the thigh. Anterior compartment's typically where you're going to see it most. This was a guy who had a thigh compartment syndrome after he had his nail. We put the nail in, he got really tense, released him, he did okay. In the forearm, the volar compartment. So McQueen looked at trying to say, well, what if we look at people who we did monitoring with, or people we just do clinical assessment with? And again, the clinical assessment didn't look so great. So they found that the time to presentation, from presentation to fasciotomy increased, and a higher rate of late sequela. Not surprising if the one follows the other. But then they also found these delays to union with this. So maybe we just all measure them. The problem is we're not very good at that either. So this was a study out of shock trauma where they looked at a bunch of tibia fractures, analyzed it based on the call schedule, essentially, which is pretty random. 7 different physicians, and this is what ended up happening. So your risk of having a compartment syndrome directly related to who was on call. So that means it's probably, right, if you have a totally random call schedule at the same institution over a long period of time, there's something else going on. And if you look at the gray bars are the physicians that had compartment syndromes, and if you look at the white bar, that's their tendency to measure a compartment pressure. So it directly tracks. So basically, the guys who measured compartments released lots of compartments. The people who didn't measure compartments didn't release compartments. But again, who knows if that's real or not. This just sort of is the same kind of thing. This shows those percentages. So the people they were measuring, basically, most of them had compartment syndrome. So they kind of knew what they were going to do going in. But again, if you're defining it based on having a fasciotomy, it's kind of circular. So again, the AAOS came out with a CPG on this in 2018, but it sort of goes back to all the stuff that we've said. There's kind of limited evidence to use just clinical exams to rule it out if the person's awake. There's no data for when they're obtundant. We all kind of think, well, if they're obtundant, we just measure the compartments, but there's no great data on this, so that just came out as a consensus statement, but with no weight. And then pressure measurements, again, same sort of thing. They said, well, it's probably good to measure it, but we're not sure. And if you are going to measure it, then probably good to do it continuously or at least serial measurements. So the take-home point is, this thing that's been around forever and we've kind of all know about and learn about from day one of orthopedics, we really have absolutely no idea who actually has this because we define what it is based on what we think it is.
So any question? There's a question.
Hello. Sir, can I ask a question? Yeah, I'm Dr. Praveen from Patna. I have to ask that if you suspect there is high chance and high index of suspicion of impending compartment syndrome of the leg with fractured shaft tibia, is it better to fix it at the first instance?
So you say if you think there's a compartment syndrome, do you fix it right away? I think you stabilize it right away. It depends. So I'll release them. If I think they have it, they get released.
Definitive fixation can be done with interlocking nailing.
No. So nailing tends to increase the intracompartmental pressure, and it should not be done. Especially you say that you have a high index of suspicion. Please don't do it. External fixation and stabilization is the way to go ahead.
Without reaming, it should not be done even. Okay, thank you.
Some of those I'll also wait because if I go in and release them and now they have these wide open compartments, I want to coordinate with my plastic surgeons to make sure we can get it closed before I have definitive hardware in. We have a very active plastic surgeon with us, or surgeons with us. So if we know they're going to close them soon, then I'll favor hardware early, but it depends on when you're going to get it covered if you have your definitive hardware in there.
So can I fix that fracture with plating or anything and again release the compartment at the same time? Thank you, sir.
Same question again.
Yeah, I wouldn't put plates in if I'm releasing it because then they're just sitting open, essentially. So if I'm not going to get it covered right away, then I just release it, put it in an X-Fix, and then come back later.
I think we can have the question later after the session. We will come back to you, note down the question. So we go ahead with the next talk.
All right, so the next talk that I was assigned is there a role for non-operative treatment in fractures? And initially I saw this and I thought, well, it's going to be a pretty short talk. It's just, this is it. That's the whole talk right there. But we're going to go into a little bit more detail than that. So I want to just, I think I reflected a little bit on my own practice when I got this topic. And I think maybe never felt older at any point in making a talk ever in my career. So when you are a hammer, everything looks like a nail. This is a saying that we have in the US. You either have it, I assume, in India, or you have something very similar. Meaning if you're an orthopedic surgeon, everything looks like it needs to be fixed, right? And so initially I changed the title of this talk to When is there a role for non-operative treatment of fractures? And then I decided that's not even probably the best thing. It's probably when is there a role for operative treatment of fractures? Because I think we should, even as surgeons, we should still be thinking about the most conservative approach possible in terms of the patient. Fractures know how to heal themselves in a lot of cases. And we shouldn't be doing surgery, which is an unnatural phenomenon, unless the patient really needs it. And so I found a couple quotes online. These are not my quotes. But good surgeons know how to operate, better ones know when to operate, and the best ones know when not to operate. And then it takes wisdom, experience, strength, and courage not to intervene. And I would agree with this. I think some of the most challenging management I have in my clinic is patients who I have not operated on, and I'm trying to get them to heal and rehab with their fracture non-operatively treated. So sometimes surgery is not a choice, right? Sometimes we don't have to scratch our head about this. Sometimes things just come in that there's no question that they need surgery and there's really no other way to go. So these, I think, in some ways are easier. There's no moral dilemma here. There's no long discussion with the patient about whether they want to go forward or not. That, by the way, is a tree trunk in his shoulder. And then there's cases where surgery is the norm. So we have essentially gotten into the habit of doing surgery all the time for most femurs, hips, bad intra-articular fractures, because we know that the outcomes are better and patients mobilize faster when we do surgery. So this is less of a dilemma as well, right? Because we're pretty confident that we're doing the right thing in these cases. And then there's some cases that we'll see in clinic where surgery, would have been nice, but it didn't happen. And then the patients are less well off because it didn't happen. And so when is surgery the exception to the rule? When should we sort of look at surgery as the plan B, not the plan A? So I would say for sure in pediatric fractures. I treat a lot of pediatric fractures because the center I work at is the only level 1 trauma pediatric center in the whole of the southern aspect of our state, which is quite a big number of people. Not compared to what you guys take care of probably, but big for the US. And so a lot of pediatric fractures we will try to treat non-operatively as long as their alignment is maintained. So we will put people in casts, little kids in casts as much as we possibly can. And there's obviously going to be exceptions to this, right? So a lot of these bad supracondylar fractures, there's really no attempt to treat those non-operatively. They do not do well. They displace, and we pin them. But for the most part, most of my pediatric fractures at least get a trial of non-operative treatment, especially when the kids are quite young. As they get older, it's a little harder. And then non-displaced fractures or very minimally displaced fractures, I think our default should always be for non-operative treatment unless we have a really compelling reason, like a non-displaced femoral neck stress fracture or something like that, where we really think surgery is the way to go. So here's just an example of a simple ankle fracture treated non-operatively without any issues. And so then I wanted to sort of look at when is surgery common but not always needed. And this is, we have talked about this all day yesterday. So some of these people are not, some of these cases are not new. When you look at this, this is people we talked about in my proximal humerus talk yesterday, where we take the same fracture and often, you know, if you ask the room, 50% of us will fix it and 50% of us will let it heal. And turns out that the patients don't care. They do the same at 1 year. And then similar thing, Dr. Golden's lecture from yesterday about the clavicle. Most clavicle fractures will do just fine on their own. Most clavicle fractures will do just fine if we fix them. And at 1 year, there's really no difference in functional outcomes. And so and these are cases where we can do surgery. We are a hammer, we see a nail, but we don't necessarily have to do surgery. And so I think in each of these cases, there's exceptions, right? So here's a clavicle fracture that I would argue is pretty wildly displaced in someone who's very active and also very young and very slim. And so that was tolerated poorly. We did try to see if it would realign. I'm not sure why we tried, or I tried, but it didn't. So that ended up getting fixed. So there are exceptions, you know, when we try non-operative treatment and it doesn't go well. And so I think if we're going to use non-operative treatment as our plan A, we always want to make sure that we know when to transition into plan B for surgery, so we don't end up with a bunch of patients like Dr. Wickstead's talk from yesterday who just were neglected for months on end with their non-unions and never taken to surgery. So here's another example of a fracture that very often can be treated non-operatively and then very often gets treated operatively. And so no difference at a year for either of these two. And then we have a patient who has a similar fracture. I think you could argue a little bit more of a high-risk pattern, right? A pretty short, almost transverse but short oblique pattern. This is a 48-year-old, quite muscular person, doesn't tolerate his brace well, and he's a construction worker, so he can't even leave the house for work until this gets really healed. And so at 2 weeks, he looks okay, and then at 6 weeks, he looks less okay, but there's really no callus and he has gross movement. And so then you sort of tried plan A, you really did give it a try, and it failed. And so we went ahead and did the ORF for him at that point. But we certainly tried to have his body heal the fracture naturally on its own without an intervention. And so this is another similar case. This is a 26-year-old prison guard. So he initially had a fracture that I think you could also argue has some features that make it high risk for failing non-operative treatment. But we tried 1 week, and then at 6 weeks, he looks worse, and he's maybe more mobile than he started. And so we, at that point, decided to move forward with surgery and plated him. And so I think sort of the point here is that non-operative treatment very rarely does harm, as long as you know when to convert to a more aggressive treatment if it's not working, and what you're looking for in your x-rays and your follow-up that indicates that you may need to try something different. And so I do want to talk a little bit, just briefly, about this type of fracture when surgery is the norm. So hip fractures, proximal femur fractures, intertrochanteric fractures, subtrochs. We sort of assume that this is going to be treated operatively, I would say, but I do think there has been a shift in the US maybe in the last 15 or 20 years, really looking at patients who are very elderly and sometimes demented or minimally functional, and just trying to figure out, do all those patients benefit from a surgery on their hip? Or is this fracture the same thing as a stroke or a heart attack? Is it an indication of organ failure in an elderly person who is at the end of their life? And so if we think of it as a stroke or a heart attack in somebody who has dementia, who lives, you know, in a facility, who really has a very low quality of life, then we probably wouldn't argue to do surgery for the stroke or the heart attack. But we often argue to do surgery for the broken hip. And so I wanted to bring that up briefly, just because I do think, I don't know if it's happening in India, you can tell me, but I think in the US there is at least an evolution where people are talking more about whether elderly patients are actually best served by surgery for their hip fractures, or whether essentially comfort care or sort of more of a hospice model is the better way to go. And so there is at least a little bit of literature out there. This is just, I think, starting to become something that people are talking about, doing studies on and publishing about, but this one was published relatively recently. 172 patients with proximal femur fractures They were given the option for surgery or no surgery, so about half of them chose each of those. And the patients themselves probably didn't choose, their caregivers or proxies chose, right? Because they're patients who are frail, institutionalized patients, and the vast majority of them had a degree of dementia. So quality of life scores were performed by proxies and caregivers, so not really the patients, but the people who are around them, who care about them. And in the non-operative group, the quality of life scores were not inferior to the surgery group. And adverse events were less frequent in patients who did not have surgery. The 30-day mortality, as you would expect, was way higher in patients who did not have surgery. And then when you ask the proxies and the caregivers, 51% of those in the non-operative group rated the quality of dying or the quality of the end of the life of their loved one as good to almost perfect. And so they felt that actually if someone had to pass, that this was a very humane and comfortable way for them to go. And so treatment satisfaction was actually quite high in both groups. So I think this is something that we don't talk about maybe as much as we should, but I wanted to bring it up since we're talking about non-operative treatment of injuries. But in general, non-operative treatment I think will always have a role for some fractures. It should always have a role for some patients. My recommendation, for what it's worth, is to use judicious use of surgery for those who need it most. And then I think as an evolving conversation, consider the role of surgery in end-of-life care.
One quick question. Yeah, please. Malhotra sir, you can come and take the stage in the meantime.
Hello, Krishna. I think it is very surprisingly you told 83% mortality in 30 days for IT fractures. We are managing a lot of IT fractures conservatively in our place, over 90 plus. We're looking after them so well.
Can you repeat the question?
I'm sorry, we can't hear you.
She just told the mortality increases by 83% for non-operative IT fractures in 1 month. It is very surprising for us as Indians. We are managing a lot of patients conservatively.
So sorry, it's actually really hard to hear you from up here, but I think what you're asking is for that last study, comparing the mortality rates for the non-operative versus the operative patients, and just looking at basically a really high percentage of the patients who were treated non-operatively passed away quite quickly, but also quite a high percent of the patients who were treated operatively passed away. And I think that's a little bit to do with the subset of patients, right? So very frail, institutionalized patients, many of whom have dementia. So the very sickest or most infirm of our hip fracture patients, so a lot of those numbers are higher than we would expect for hip fractures in general. But that patient population is really just the people that are maybe the ones closest to hospice before their fracture, and maybe that therefore the closest to death anyway. I'm not sure if that answered your question.
But I'm not sure whether those who were not taken for surgery were anyway far worse risk for surgery. That bias sometimes is there. So I don't know whether the choice of patient for surgical or non-surgical treatment was purely like uniform, or those who were anyway bad surgical risk were chosen for conservative treatment, which would explain why a higher proportion died.
Yeah, no question. I absolutely agree. And I think, and we can talk about it later, I don't want to get too much into the woods about this as well, but we look at outcomes, I think, and we report outcomes of death, and we report outcomes of death as if it is a bad thing. And I think not everybody would feel that way, especially with their loved one at the end of their life, who may not have a great quality of life. So I think some of the patients and families who chose the non-operative group, chose that end for their loved ones as comfortable as that could be.
So final decision to operate or not operate depends upon patient relative, not the surgeon. The final decision to operate or not to operate lies with the patient.
Yes.
It is not with the surgeon.
The patient's caregivers, I guess, not actually not the patient themselves, yes.
Good morning. I'm Dr. Achyut Prasad from Andhra Pradesh. I would like to say, in the slides observed, there is angulation of the fracture humerus when you immobilize it in the flexion. I suggest if you immobilize it in the extension, the cast itself adds to the necessary traction And biceps and triceps, they brace the fracture nicely, and it can be treated conservatively. This is my experience.
Yeah, point taken. If you can maintain reduction, we can continue it. We'll go to the next.
Thank you, Christina. That was a great talk, and I'll repeat some of the points you made, but we also believe that the hip attack is a sign of failing physiology. So it's very important to talk to the relatives that the patient may die in spite of everything which we do. So I'm going to talk about the tips. So we know that in elderly, these fractures are low energy mechanisms, and the difference is that there is metaphyseal compression, comminution, splintering, and deeply impacted articular surfaces. And, they are totally different ball game. The bone density is poor, bone matrix is deficient, mechanically the bone is weak, they are prone to injury with trivial trauma, and then of course the osteosynthesis and the rehabilitation are challenging. And like we have said, it's a real challenge to get them back on their feet and get them independent. And then of course we have to look at their pre-injury status, cognitive history, particularly we just had that discussion about the demented patients having hip fractures, and then what are the living arrangements, and then of course we want them to be up and about whenever there's a fracture. And the fracture care has to be personalized to every patient. And of course, the medical condition and the comorbidities will decide what is done. And then primary aim should be that the patient should survive this injury and then have minimum morbidity and mortality. And the usual perspective of the orthopedic surgeon is that you should have a stable fracture fixation to allow weight bearing to aid healing, as Christina showed, prevention of the secondary loss of fixation, which is the fear in everybody's mind, patient or the surgeon, and then of course to find balance between minimally invasive and restrictive surgery. And then, so the first aim is to keep the patient alive, then fix a fracture, then have a multidisciplinary rehab, and then prevent the further fractures. And then the elderly patients, the functional demands are totally different. Long-term results we are not worried about. The surgery is more difficult, less predictable, and risk of complications is much higher. So risks are higher and the benefits is lower. But how do you decide that the bone quality is poor? You don't take a acutely fractured patient to the bone mineral density measurement. And this is an assessment which is known. This is intraoperative physician or surgeon assessment scoring, which says when you are operating and if you get a feel of the bone, whatever your assessment is, that correlates very well with the bone mineral density measurement. So your impression is extremely important on the table because that has been shown to correlate with the bone quality. And then, of course, there's an excellent role of conservative treatment. The first cardinal principle, which already has been told by Christina, is treating conservatively is not neglecting. Particularly, we saw it during the COVID period. So I'll just take you quickly through the osteoporotic vertebral fractures, which are treated. We just designed some indigenous braces to have a low-cost thing. And there are other braces and techniques like the doctor from Andhra Pradesh said. You can actually use your braces and supports, whatever. But then if you have stable undisplaced fracture or displaced fracture which are stable after reduction, or the patient is unfit, you are very well within your rights to treat them conservatively. Proffer trial is one of the most classical trials which talked about displaced proximal humerus fracture. We conserve proximal humerus in patients in 80s and 90s very often, and it has been shown even in the follow-up trial at 5 years that it makes no difference to the results. Similarly, the reverse shoulder arthroplasty versus non-operative treatment and 3 and 4 part fracture. This is one of the patients who had a CA breast and showed excellent result with a 4-part fracture. So conservative treatment does have a role there also. The olecranon fractures, all these have been described in literature that you can treat them conservatively, distal radius, and even the distal humerus, and then the AIM trial for the ankle. The challenge is that you may have insufficient stability and secondary displacement. The patient compliance may be an issue. The patient's cognitive functions may not be that good. And then the cast and all may really prevent them from doing the activities of daily living. And then when they can't move much, they will have associated morbidities. But that is the principle that you should think. And sometimes the conservative treatment is better than patient, even if what the treatment suggests, like this is a stress type of fracture neck of femur, which is, as per the book, should always be operated. But the problem is she's a doctor's mother and her T-score is 6.9. Once you have that kind of T-score, I don't know where my screws are going to get a purchase. So we just started with teriparatide, and lo and behold, it just healed. The stress fracture healed just with the teriparatide without any other problem. The acetabular fractures, which are so often an indication for fixation, don't do so well in elderly geriatric patients. We all know that there are high rates of failure, and now I would not fix them. Actually, I have the highest series of acute total hip replacement in these patients rather than condemning to a secondary procedure when they have been non-weight bearing for 6 months, 8 months, or 1 year. And it has been done using the octopus cage trabecular metal construct. But there is sometimes you should just take the, bite the bullet and take them through the total hip rather than fixing and then having them doing poorly subsequently. The other thing is, of course, it needs the multidisciplinary geriatric management, which is again a very important thing. This is a patient who had a fracture, then developed pneumonia, intubated for 7 days. And these are the kind of things which are very common in India, and then you do need the physicians on board, so geriatricians or the multidisciplinary care has been shown to be a very effective and very safe and gets good results for these patients. So do involve your physicians in the care of this to reduce the mortality and lower the costs. Now, the next is that in fact, elderly, you need sometimes a special approach. So this is the lady who had this fracture operated some 20 years back, and she got this fractured neck of femur without even realizing. Her one son is a doctor and the other one is a lawyer. So came and drilled me for 2 hours about what I'm going to do about this. So I just thought that the first thing to do was to take out the nail, which was in for 25 years. I took it out, then I put a prophylactic distal femoral plate. Once I put that, I removed the top screws and then did a cemented hemiarthroplasty, and she was up and about the same day. If I had fractured her while doing hemiarthroplasty, I would have still been forced to put a plate, but then she would not have been able to bear weight so readily, and then she would have been in for a healing. So this is what we published, that sometimes in an osteoporotic bone, you must protect the bone before you really start treating what the patient came to you for. Another example of this kind of thing where there was a prosthesis underneath, nail cutting out. Protect the bone all along and then do your hip on top. Don't just jump on to do the hip. You might actually just fracture it while you're trying to dislocate it. That's the follow-up. When you do these kind of pinning, see this, you must try to get a screw up in the neck. That's very important to prevent the stress riser. And then, of course, you can have special devices, the locking attachment plates or the attachment for putting the locking screws in these. The other one is the emergency arthroplasty. I have always, I was mentioning to Dr. John Wickstead yesterday, I would do a distal femoral replacement for a very elderly osteoporotic with an arthritic knee and not put her through the implants and wait for it to heal and then remove all those implants. But there are proven arthroplasties relevant to some challenging osteoporotic fractures. Hip, we have been doing it all along. Then we know that in hip fracture, the dual mobility has done quite well. Doing it in knee is somewhat demanding. The revision components are often needed and the complications may be common. This is proximal tibial fracture, the arthritic knee, and then we just went ahead and did a fixation with the primary knee. This is what we did about a few months back. This was a lady who was told that she can't have total knee because she's morbidly obese and bad knees, and she fell down and broke her tibia. So what we did was put a sleeve, metaphysial sleeve, and the knee implant which you see is not from the same company. It's more of a generic principle of putting a sleeve there and then put a rod and an implant through this. And she had total knee and she's walking comfortably, and she wants to now get the other knee done also. So the same problem about the arthritic knee with osteoporotic distal femoral fracture, I would much rather go and replace and put the patient back on their feet. However, this was all before we didn't have the sleeves, and the distal femoral replacements were not commonly available in India. Now they are, but we use sleeves much more common. And there are reports in literature of using the modular constrained implants for comminuted intra-articular fractures in these cases. In shoulder, it can be done as an alternative to fixation or the failure of fixation, and that is all, like I said, for the elbow. So elbow, shoulder, knee, hip, it is all right to do primary arthroplasty if required. Osteosynthesis has a great role, and especially in the lower limb fractures, and I'll not spend much time here because we have heard about this all along. So we have the special devices for strategies for whether to use the nails primarily in osteoporotic or nails with plates when the bones are very poor. The locking plates, of course, have revolutionized the treatment of fractures in the osteoporotic bone. So all parts of the body you have anatomical specific or the special locking plate which help you get through with a good thing. But of course, always avoid a very rigid construct because that's what is doomed to failure, and that's what you should always keep in mind. Don't have a very rigid failure, and then we know that you understand the fracture anatomy and the biomechanics, and always have the right principles in mind to put the calcar screws even there. So is a variable angle technology has actually revolutionized all fractures, including the distal radius. So that is that's the fixation of some fracture. We heard about far cortical locking from Dr. John yesterday, but essentially it's not more important than the working length of the screw, of the plate, and that's what is important. And you can have the hydroxyapatite coated implants. This is something all those who are experienced with the surgery would know, that when you see something, you know that it is doomed to fail. The next cardinal principle is that you do need the augmentation. So I have very low threshold for using the calcium hydroxyapatite cement in these things, and even if required, then I avoid putting bone cement, but then it's the calcium phosphate cements and hydroxyapatite cements are available, particularly in injective form. I would have very low threshold for using them in all osteoporotic fractures. The next one is, of course, the allografts can come to your rescue. This is a lady who was 72-year-old, non-union of distal fracture, and an intramedullary fibula, either autologous or allo, has been shown to be beneficial in femur, in humerus, all that people have successfully treated these. We use a lot of cadaveric allografts, so we do something called strut allografting to support very poorly osteoporotic bone. This is intramedullary fibula now here, and another example of fibular strut. But this is a general principle which we use in revision arthroplasty or very severe cases. This is a lady who was 75-year-old. Somebody took her to theater for revising the right hemiarthroplasty. While he removed the hemiarthroplasty, he ended up fracturing the femur, and the patient went to ICU. So we shifted to my ICU from there, and there was no point in keeping that obese lady in bed. So we went ahead, put in this kind of modular hip, but then we protected it with the strut allografts all around, and she went on to live for 12 years after that before she died to a malignancy. The next one is technology is a great asset. Again, I'll not spend much time here, but then it has a lot of applications, and including the robotic. Minimally invasive techniques are fantastic. You had this elegant talk by Dr. John Wickstead yesterday talking about how you can just fix these by being minimally invasive. So that is the other thing you can actually, particularly for the spine. And the 12th cardinal principle that you must prevent future fractures. That's your role. If you find a hip fracture in a patient who had hip fracture operated on the other side and the surgeon didn't anything, I think the surgeon owes it, and he has to own the responsibility for making sure that the patient is treated for osteoporosis. So fracture liaison service is a great tool to keep them, and of course the fall prevention advice also has to be given by us. So this is the conclusion of my talk. I think messages are quite clear. I'll not go through all these, but just say that these are very fractures which need individualized, personalized kind of treatment for every patient, and no one shoe will fit all, and you will keep on looking for the right solution for every patient. Thank you very much for your attention.
So the next talk is on comminuted fractures.
So again, comminuted fractures is, kind of a big topic for 10 minutes. We'll try to get through this as much as we can. Again, the place where I practice has a lot of gunshot wounds, so a lot of these are going to be gunshot wounds. I don't know, that's probably not as big a problem here in India, but they do result in a lot of comminuted fractures. So first, this was a guy, this is going to sort of show what you don't do. Maybe this is a 48-year-old guy. This is somebody I saw early on in practice. He had fallen, he had open wound, he was working on a boat, he owned his own dry dock. Came to him with this comminuted fracture down into the pilon, and we fixed him, put a couple little mini plates there, there's a couple stage procedures, eventually got a bunch of hardware from the back and the front, a little bit on the medial side, got his fibula fixed, right? We were high-fiving in the OR, nice reduction, everything like that. So 4 months, he also had a flap put on that. 4 months later, still didn't look like there was a whole lot of healing going on. Every once in a while, he'd had some drainage, so we ended up taking everything out. Still wasn't really healing, and then that's how he ended up. He was actually pretty functional with his BK, but obviously not what you're trying to look for. So the take-home point with that is, sometimes you can't, and a lot of times you shouldn't try to fix every fragment. So if we try it again, this was a person later on, similar kind of fracture. This was a motor vehicle crash instead, but same sort of thing. Comminuted, goes down into the pilon. Much less hardware, fewer incisions, smaller burden on them, and she went on to do fine. So part of the take home with that, again, is that your soft tissues matter, that we're not just carpenters, we're physicians and doctors, so it's a living tissue, and you can't just fix everything and to make it look perfect. This was a 42-year-old. She's a tattoo artist. She's one of the nicest patients I've ever had. She was literally in her front yard, and somebody just shot her, which was pretty unfortunate. She had a radial nerve palsy, which is a problem if you're a tattoo artist. We went in, explored the nerve, plated her, but left a lot of the soft tissue around there, didn't try to reduce all the little pieces. It probably wouldn't have been possible anyway. And her radial nerve palsy came resolved by 13 weeks. This was her a year and a half out. She's totally fine. She's back at work, owns her own shop, works out every day. So the take home with that also is that the location in the bone matters, especially with comminuted fractures. If comminuted fracture at the joint's a very different animal than a comminuted fracture in the mid portion of your femur. This was a guy, 17 years old. Again, the vascular injury, we saw this one a little earlier. Ex-fix and then eventually fixed with his nail, and a little slow to heal, but does go on to heal. This was a different guy. He was a suicide attempt, drove his car at high speed into a wall. He had a ton of fractures beside this and a lot of other injuries, but you can see there's comminuted fractures up in he's got a neck and a peritrochanteric and down here. He also has a separate supracondylar fracture which comes all the way down into the joint. Let's see there. So we took him, this was open as well up by the top, manipulated the neck as best as we could. We had some position restrictions because of his head injuries and some other injuries, so we got this in the first go around, and then eventually brought him back about 8 days later to fix the supracondylar part. And again, the comminuted part of the supracondylar, we wanted to make perfect. The stuff in the shaft doesn't matter as much, and he went on to get at least to this far. Then he moved back with his parents so they could watch him more. But he's got robust callus forming everywhere, so he's going to go on to heal okay. The other thing we like to use is a lot of mini plates. I think they're super helpful. This is one of the options. This is just 2.0 plates, 2.4, 2.7. So they give you a lot of different options. I think they're super helpful for controlling some of the little pieces, and they get your hands out of the way, they get the clamps out of the way. They're much quicker to put on, so you don't need a big span, and they hold it well enough until you can get your definitive fixation in. So this guy got this little plate to hold some of the comminuted fractures back together and holds the alignment for you, and then you can put the regular plate on, and then that goes on to heal. You can use them, obviously you guys all know that, with acetabulums. This is somebody who had this comminuted posterior wall. There was some impaction with that as well. And then we just made these out of smaller plates so that we could fit them to the walls, whereas the pre-done spring plates are way too big. He's got a couple other little mini frag plate or screws in here besides the main hardware just to hold some of the little pieces down to hold the impaction back up, and then the main plate. We also sometimes use some flexible nails. These can be kind of helpful, even if you use them in places maybe you wouldn't think to use them. This was a gunshot as well. She had a big wound, and we ended up just putting a flexible nail across that to try to get it to move a little quicker without having to do a bigger dissection, because she already had a bunch of soft tissue injuries in the area, and that healed up fine, and her motion was fine afterwards. This was a 31-year-old, another motor vehicle crash. First put into an X-Vix so we could kind of see what was going on and let some soft tissue rest. You could see lots of comminution of the fibula, comminution into the tibia, this big chunk missing. And again, we use this little mini plate to kind of stabilize that. She had a wound over here, so we ended up using that to get the hardware in rather than to make some more wounds on her to try to preserve as much soft tissue as possible. And then put this flexi nail up to maintain just the fibular length, and she went on to heal. She walks around okay. She works on her feet, so she gets a little tired by the end of the day, but otherwise feels okay. Some of these, when they're really comminuted, getting contralateral films is really key, especially on areas where the curvature matters or the actual alignment matters. So this was someone who had a gunshot wound. You can see multiple fragments in there, really comminuted through the radius. We got some contralateral films, and then took her, there's a couple mini plates here, there's one here, then put the bigger plate on. But what we were able to do is you put the mini plates on, compared it to her other side, and managed to restore it pretty close to what her other side looked like. Another important thing with this is you always have to remember, again, we're not just fixing the bone, we're treating this patient. So make sure you're treating the patient for what they're going to need. This was a 61-year-old trip and fall, right? Fairly comminuted. She was originally taken, she was put into an X-fix by one of my partners. You could see she's still a little bit subluxed here. She was a little subluxed in the splint as well. A couple days later, she said she struck her leg on the bed. The whole thing was a little unclear. She said she didn't have any pain, so we thought probably she's a little neuropathic as well. And we got repeat x-rays. You can see she's somehow dislocated despite the X-fix being on. We took her back, put it in, and she was still kind of unstable, so we put a couple K-wires up here just to hold it for the time being, let the soft tissue resolve. The important thing with her, and most people, you can say, well, that's just essentially a tri-mal, maybe a peel-on, just fix it. So she's 61, she's diabetic, she's got peripheral vascular disease, she smokes 2 packs a day. Also a really nice woman. She had a horrible set of circumstances, so her son's body, her guide dog for the son died the day before she got injured. Her husband's a double amputee, she's the primary care provider, and she basically was like, I'm going to walk on this, there's no way I'm not going to, I'm the primary care provider. They come from a pretty poor area. They could not afford any help. She was not going to go to rehab because she had to get home to help everybody. So we did similar to what Christina showed you before with the hindfoot fusion nail. Again, she's probably neuropathic as well, but she went on and healed fine. She's very happy with that and is back taking care of the family. Remember, ultimately, you need living bone. So this was a ballistic tibia, open wounds, a bunch of bone missing. Got an X-fix, brought him out to length. You can kind of see where some of the gaps are. So in coordination with the plastic surgery service, put the nail down, put a big block of cement over where the defects were, let that sit for a little while. I think we took him back at about 9 weeks and bone grafted him. The plastic surgeons elevated their flap, took the cement out. There's the bone graft going in. You can see I do this little thing with golf balling the cortex to kind of decorticate it to give you a bigger surface area to kind of get for graft incorporation, and he did pretty well. It looks like he's pretty much healed, had no pain, was walking around. Remember that, we like to put plates on the inside, but external fixators have been around for a long time and they work as well. This was somebody who had shot in the distal radius, pretty comminuted there. Really not a whole lot left, but when we took her to the OR and just kind of pulled on it and strained it out, it kind of looked okay. There were some big wounds there too, so we just left her essentially in the X-fix, and did form a pretty good column of bone there. This part's missing, but they don't have any pain, and we talked about bone grafting it later, and the patient basically refused because they said, well, it doesn't bother me at all, and the motion was fine, so they didn't want to do it. And a lot of times you need to do all sorts of things. Take all those things that we just talked about and put them all together. So there's 2 examples of this. This was a 46-year-old guy, alcoholic, cirrhotic. He had some lymphedema, very poor skin envelope, this really comminuted peel-on fracture. He was originally taken and just put into a standard X-fix, and we talked to him about all his options. Ended up putting just a single screw to kind of get the fibula where it was supposed to be to help with guiding where to put everything else, and then just put him into this circular fixator. left him with that. He had some comminution and bone loss through there, so eventually took him back, put a little bone graft in, let the frame stay on for a little while longer, and then took that off, and he did fine, walks around. This was a 40-year-old police officer. He's on the SWAT team. They were serving a warrant, and he got shot with a high-powered rifle. Comes in with that x-ray, not a whole lot of bone there. That's what his tissue looked like. Again, his knees up towards the top, foot down towards the bottom. So we had taken him, this was our first operation, put him in an X-Fix. These are antibiotic beads to try to clean out the area. We took him back for another debridement. The plastic surgeons came in at that point to kind of see what it was. We did an angio on the table at the same time so we could figure out if he could get a free flap. His foot was actually warm. He could move his foot. He could feel his foot the whole time. So we put the rod down. They put a big free flap on, which you can kind of see here. And then we found as much of the little cortical pieces and put them with just a couple little mini plates just so there'd be some sort of continuity up here to kind of define the canal, get the length right, and to maybe give it a surface onto which to heal. This was him about 5 months later, wasn't healing a whole lot, but didn't really hurt. These are a couple selections from the CT, so you can see, still didn't quite make it across there and a big bone defect in the back. We took him back, changed the nail out, got some bone graft from his ipsilateral femur. We put some infuse in as well to kind of throw the kitchen sink at it, and then he healed up completely. He's actually back at work full-time as on the police force in regular duty, so he did pretty well. All right.
Yeah, so we can have some questions. So some of them had a question. So I had one question for you from the compartment syndrome. So, so in here, we don't have the probe. How often do you use probes to diagnose compartment syndrome, and what is your actual protocol to diagnose it?
So we'll use the striker a little bit, but for me, for the most part, it's still fairly clinical diagnosis. And essentially, it almost comes down to as soon as we think that it might be a compartment syndrome, generally we just take them and release them. There is some morbidity to releasing compartments, but obviously there's much more morbidity if you miss them. The obtundant people will measure, and we'll sort of measure them, serially. We don't really, you can set it up with just a kind of an A-line setup and the slit needle and all that. But that depends on where they're located. Obviously, if they're obtundant, they're going to be in the ICU, so then we can monitor them. But
so the saying still goes true. After 60 years, we know it's there, and we have to jump into it. So again, so just to summarize, it's the same surgeon at multiple serial point of view. If he has a high index of suspicion, he should just go and do the fasciotomy. That should be the takeaway message. Yeah. Any questions for the osteoporotic fractures? So what are your 2 important tips for osteoporotic hip fractures?
The most important is reduction. Second most important is reduction. The third most important is reduction. But having said that, because she showed so elegantly yesterday that even if it's a positive reduction, which is so-called, if there's no contact medially, it is again going to be failure. And sometimes you will get the interposition of the psoas tendon, it's called reverse epsilon sign or epsilon sign. So be careful about this, and must, in a bad comminuted fracture, must reduce and hold it there till you put your nail in, as again was shown. So a lot of surgeons in India do pass KYs, do anything which you want to do, or circlage or something. If there's a spike, do something to hold the reduction while you put in the nail, and once you know that it is in place, reduction is still, and then only go ahead to put the screw and the lock.
80 years plus bad trochanteric fractures, nail them or replace them?
I always nail them, even if I'm primarily an arthroplasty surgeon. Only once in my lifetime I was operating on a colleague's mother, and I realized that the head was so soft that the nail had started, the screw had started moving within that. I loosely closed it, turned around and did a replacement. You should have a modular prosthesis with you. Try to put a bipolar, don't go for a total hip. and make sure that you take care of the trochanteric fragment. So it's technically challenging. A lot of inexperienced surgeons just jump into it. Limb length equalization is a challenge. Restoring abductor mechanism is a challenge. Okay, putting it in correct version is a challenge. So unless you know what you're doing, don't jump into it. But nail works in most cases, even if they are severely osteoporotic. The only thing is now a lot of people talk about putting the cement through this thing, and I've seen practically leakage in most of the cases which have been done. So I would be a little wary, but what else if you reach that stage, maybe the patient is better off with the arthroplasty than a nail.
I wanted to say one thing about compartment releases, because I think sometimes from even the community hospitals in the US, I will see people come in with just a tiny little fasciotomy, just a little tiny wound that because the surgeon who did the fasciotomy didn't want to be too invasive. And I guess my personal bias, my opinion is if you're going to do a fasciotomy, just make it really big. Make sure you release everything, or you may be wasting your time. I don't really think there's a role for sort of like a little tiny minimally invasive fasciotomy in trauma.
One last question.
Yeah. I'm Dr. Dilip Shah from Mumbai. My question is to Dr. Malhotra. By the feel of treating the bones, like you try to drill and you feel as if you're drilling in butter, you know it's porotic bone. When do you do DEXA scan? When do you start the treatment like teriparatide? How long do you give teriparatide?
So those are excellent questions, sir. I'll try to answer them in as short as possible. Number one, every elderly osteoporotic patient is vitamin D deficient. I had a bad subtrochanteric in a 90-year-old. Her vitamin D levels were not measurable. So anyway, first thing is you must start them on calcium vitamin D right away. And there is no role of DEXA actually in management. Once the patient is up and about, you can think about a few months later when the patient is mobile. The treatment of a fragility fracture is not dependent on measurement of DEXA because the diagnosis is already there. Once you have a fragility fracture, you don't need DEXA to prove that. And that is the least of my considerations. My considerations are if her kidney functions are fine, she is replete with calcium and vitamin D, and how soon I can start her on osteoporotic treatment, which will require that her calcium, vitamin D, PTH should be normal, and then and the kidney function should be normal, and then I can decide about giving her right treatment. So that time it's a bailout. So all that you are saying, sir, is very, very relevant for elective surgery. So a lot of people are now saying that a patient comes to you for elective hip replacement or elective knee replacement. Do a bone workup if you think she is going to be osteoporotic. Start them on some kind of treatment. Elective surgery can wait. But the emergency surgery with a fracture, you will have to treat the patient and then treat the osteoporosis.
Hello.
Okay, we'll discuss that.
Thank you. Thank you, everyone. Now we move to our last session, which is controversies in orthopedics. And to chair this session, we have Dr. Chetan Pradhan. He is a well-known orthopedic surgeon from Pune. I request Dr. Chetan Pradhan to come on dais.
So for those of you who are still in the hall, we are on to the final session of this beautiful trauma conclave, and that is the controversies in orthopedics. So I would invite all the AAOS faculty here on the stage, because we are going to have a panel discussion on all these topics. Dr. Jack?
I think they might be getting coffee.
Huh? Okay, fine, okay. So
No,
for-
I think they're getting coffee. I mean, I always want coffee, but I think they might be.
And the first controversy is going to be dilemmas in hip fracture surgery. Dr. Christina.
All right, just so that we stay on time and that you guys aren't here any later than you wanted to be, I'm just going to go ahead and get started. And so there's lots of controversies, I think, and dilemmas in hip fracture surgery, but I just chose a couple. So I think these are some that stand out to me and that I see in my practice all the time. Elderly femoral neck fractures, cemented versus uncemented hemi. I feel like we talk about that so much, I decided we weren't going to go there today. And then middle-aged femoral neck fracture. I actually think this is a really interesting topic, but I think that Paul did an amazing job summarizing when he talked about the femoral neck yesterday, just in terms of the pros and cons of fixation versus early arthroplasty for someone who's in their, late 40s, early 50s, early 60s. And so I don't want to rehash that necessarily today. One thing that I see come up a good amount in our practice is severe elderly osteoporotic acetabular fractures that come in with a large amount of joint damage, and whether we should do an ORIF with a possible late total hip replacement if the joint goes on to need it, or whether we should just assume their joint will degrade and do an early combination ORIF and total hip on their initial presentation. So I want to show you some cases for that. And then we did just talk about a minute ago, but also talked about a little bit yesterday, but the very worst of the peritrochanteric fractures, whether we try to fix those or whether we go straight to arthroplasty. So this is a healthy 73-year-old female, status post-fall, who has this acetabular fracture. And I'll show you some additional images. So this is her CT scan. I'll just let it scroll through for you because I think she has a pretty interesting amount of head impaction in the fracture. They tried to reduce her in the emergency room, but the head was really stuck on the fracture and it couldn't be budged. And so we know she has impaction of her acetabulum, but also maybe some femoral head damage. We know both of those, the marginal impaction and femoral head damage, can be things that can predispose her to joint destruction. This is the sort of 3D reconstruction of what's going on. She really is, her head really is pushed a good way into the pelvis and perched on that proximal fragment of the ilium. And so when I see a fracture like this, we sort of think about options. And so I think for now, just despite my previous talk, we're going to cross off the non-operative treatment option. She's probably not going to do well. She was a healthy, independent 70-year-old. So then in my world, I am thinking, am I just going to do an ORIF right off the bat and see how she does? Or do we say, there's so much joint damage that we do an ORIF and then an acute total hip, either the same day or the same hospitalization 1 or 2 days after the first surgery. So this is what we ended up doing. So she had an immediate ORIF for a posterior approach. The surgical time was about 2.5 hours, and her blood loss was about 350 cc's. This is her post ORIF CT scan. So we got a pretty good reduction, but you can still see that there is some damage of the head, and that will become important as we go forward here. But the acetabulum anatomy is well restored. And so initially we thought, she may have a chance of doing well with just the fixation. At 2 weeks, she looked like she may have a chance, but then when you look here at 6 weeks, you can actually see, you can see it at 2 weeks a little bit, but at 6 weeks, you can really see it, that the femoral head is sort of melted away. It's just kind of disintegrated. She has not been walking on it. The head, I think, just sustained so much damage in the initial injury that it basically collapsed and degraded over time. So now she has a socket that's not bad, but she really doesn't have a femoral head of any worth. So at 12 weeks, when we'd had enough healing in the posterior column, we went back and put her total hip in. And so, that always makes me question if we had just seen this coming, should we have just gone ahead and done this at the first surgery? And so here's another similar case, not quite the same. This is actually a 69-year-old gastroenterologist at our hospital. It's always a bad sign. Status post-fall, and this is his acetabular fracture. And we decided for him that we were going to do the whole shebang right off the bat. So he had the fixation of his acetabulum done through an anterior interpelvic, and then he had the hip done through a posterior approach to separate those incisions as much as possible. His surgical time ended up being about twice the other lady, about 5.5 hours with the repositioning, and he lost about 1 liter. I would say for the extent of surgery that he had all in one day, that actually wasn't bad, but that's a lot. I would say for the average elderly person, that's a big day in the OR, and you could certainly lose 2 or 3 times that amount of blood depending on the fracture and how much bleeding you encountered. So he ended up doing well at 3 months, having had both done initially right off the bat. Here's another person. It's a little bit of a different scenario, but similar. So 68-year-old male fell off a ladder. You can see he's had some work done on the contralateral hip, and now he's dislocated his left hip. And we were able to get his left hip back in place and then do some additional imaging. So you can see he has a relatively small posterior wall acetabular fracture and then a relatively large, although probably not weight-bearing, fracture of the head. So we felt that he probably had sustained enough joint damage and had some baseline arthritis anyway that he was probably going to be someone that would need a total hip in a relatively short period of time. So we were trying to decide, is it worth fixing him acutely? Would we go make, an incision and approach, maybe put the posterior wall back and get some more stability of the posterior soft tissues? Is that worth doing? Or is it better to just leave him for now and let him heal in? Or is it better to just do the total hip now? And obviously the issue with doing the total hip now is stability. So he is a lot of inherent instability posteriorly. So these are sort of the options: acute ORAF, acute total, acute ORAF with a delayed total, or delayed total. So what he ended up having was non-operative treatment initially, and I think this was about at 8 weeks. When the posterior capsule was felt to be healed enough, he had an anterior total hip at 8 weeks. Here's another similar but slightly different patient, so a little bit of a different decision-making conundrum. So she's a very frail 91-year-old female who comes in with her total hip dislocated. We were unable to reduce her in the emergency department and initially didn't understand why, because she didn't have a lot of muscle to fight back. So we couldn't quite understand why this wouldn't go in. And then when we checked the CT scan, her posterior wall fragment, so her posterior wall had broken off, and then it had come between her implant and the socket. So the posterior wall was what was blocking her reduction coming back in. So for her, we decided that she needed an open reduction. She needed a revision of her hip. Her acetabular component had completely come out. And that in order to do that we would need to acutely fix the posterior acetabulum, which we did. So she had sort of both a new hip and an acetabular ORF in the same day, which was a lot for a frail 91-year-old female, but she also had both of them through the same approach. So it was just the posterior approach to do both of those, not, one approach, closing, flip, redrape, another approach. So, I always scratch my head when these patients come in trying to figure out what's the best thing for them or what's too much for one patient in one day. If we're going to do the total hip and the acetabular fracture, should it be all surgery in one day with one anesthesia? Should it be surgery and then 2 or 3 days later another surgery to put the hip in? Which one of those is really in their best interest and which is the lowest risk? And I actually don't know the answer. That's the controversy. I'm not bringing you any answers. I'm only bringing you things to think about. But there are some studies out there, very limited, I would say, research out there now, but it's something that's being studied more and more. So acute versus delayed total hip arthroplasty after acetabular fracture, and they were able to find 5 retrospective studies for a total of 255 patients in the literature, so not a huge body of evidence so far. 138 patients were a fix and replace right off the bat, and then 117 were acute ORIF, healed, and then delayed total hip arthroplasty. And so there were no difference in functional outcomes. The complications and mortality rates were comparable. And the delayed total hip category actually had a higher revision rate. and I'm not really sure why that is. This paper didn't really delve into surgical time, transfusion requirement, blood loss, length of stay, things like that, that I think would play into my decision making depending on how frail the patient is. This is another study looking at different publications in the literature. So indications, complications, and clinical outcomes for acute total hip for acetabular fractures. So there were 11 studies. The mean age of patients was about 75 years. The overall complication rate was about 12%. And hip dislocation was the most frequent cause for reoperation, but average Harris hip score was quite good. With acute total hip arthroplasty for acetabular fracture. So it certainly is something that can be done, and depending on the degree of the acetabular fracture, it may be something that you could do without fixation. It may be something that requires a very big, extensive acetabular fixation before the cup could go in. So I want to move on now to the other controversy that we alluded to just a couple minutes ago, but also yesterday. For the worst of the worst kind of peritrochanteric, unstable intertrochanteric fractures, are these even worth fixing? Are we essentially wasting our time? Are they just, going to fail at such a high rate that we should give up and we should go straight to arthroplasty? I'm biased. I like to fix them. I think in general they do well. But they don't always do well, that's for sure. And I think the proponents, I have one partner who is very adamant that most of these should have an early hip arthroplasty, and I think his argument is that the time that you spend waiting to see if the patient will heal their unstable fracture, as well as the loss in muscle strength that they get from essentially having a fracture that's fixed but maybe not very stable, that's a real cost, and that if we can save them from losing that strength and save them from that downtime, that it makes more sense to just do the hip acutely. And so I can see his point, I haven't converted in my patients to doing that. So I've done a couple literature searches, and really there is minimal literature to support either option, one over the other. I think it's not something that's well studied yet. Here's an example of one of those types of fractures where you have these multiple trochanter fragments all sort of floating around everywhere. We do some interventions to try to get the trochanter fragments back around the nail, back where they're supposed to be in this profoundly osteoporotic patient, and yet 6 weeks later sadness has ensued and she's completely failed very early. And so then she goes on to have her hip replacement done, and it's not a normal hip replacement. I think we just discussed that. It's a little bit more complex than average. You really have to try to get the trochanter to heal as well, and you have to take into account like length offset and stability, all of which are challenging in somebody who has a collapsed intertrochanteric or pertrochanteric fracture. So I won't belabor this too much more, but to me those are the most interesting current controversies around the hip. Elderly severe acetabular fractures, we can treat with good results with either early ORF and late total hip, or early ORF and early total hip. So both of those are viable options. There's not great data at the current time to support one over the other. So for me, I usually take into the consideration sort of the patient's ability to tolerate a long anesthesia with a lot of blood loss before we make that final decision. And then for the severe peritrochanteric fractures, fixation versus arthroplasty, I think the jury is really still out on that. I do know people who feel very strongly one direction or the other, and I tend to fall in the feel very strongly that we should at least try to fix these category. But that may also be my bias because I'm a trauma surgeon, right? So I think if you ask 10 arthroplasty surgeons, 9 out of 10 of them might say that these should all just get replaced right off the bat. And that's, I'm sorry, there's no controversy about this. So for those of you who didn't know where I grew up, I didn't actually grow up in the United States. I grew up in Australia. And it may be too soon to mention this, but I couldn't leave the stage or the conference without bragging a little bit about our cricket team. Sorry.
Thank you. So, as far as the panel discussion is concerned, there are three questions that I'm going to ask the opinions on. So the first one is the ongoing controversy, which partially she just answered. In a comminuted intertrochanteric arthroplasty versus fixation in an elderly patient, she has given her opinion. Dr. John, what is your opinion?
Yeah, I mean, I am very biased towards fixing these. And like many of the conversations that we've had here, I will typically do them lateral. And if the trochanter is very badly damaged, I will just open them. I will not fool around with trying to put a nail in and make it look pretty without opening. I'm perfectly happy to make a direct approach to the trochanter. It's not complicated to do. And then reconstruct the trochanter, get it back into one piece, and then just do an open nailing. And I find that's pretty simple to do. And oftentimes with those comminuted intertrochanteric fractures, you also have a basicervical fracture through the neck. And I find it's very helpful to pin that in place before you try to put your screw in there. And so I'll reconstruct the whole thing with it open. And then once I've got it all reduced and pinned back in place, then it's very simple to put the nail in there. And I don't hesitate at all to open those. I want it to look right on the x-ray. If I'm committed to fixing it, I want it to be right. So I don't try and do that on a fracture table. I don't try and do it minimally. I just open it.
Right. So you would fix everything and then start immediate weight bearing as tolerated.
Yeah, I'm
Robert?
pretty much the same. I fix pretty much all of them. And I don't open too many of them. Some of them, if there's a little bit of a kick with flexion, you stick a cob down the front and kind of get it lined up. Some of them, if they're really comminuted, especially if they go down towards the lesser troch, and a lot of the older patients have a really big canal, I'll preference back to being a long nail as opposed to a short nail. I've seen a bunch of them come in with short nails where sort of it stays in the head okay, but the whole thing kind of tilts in the canal. Yeah. And they go into varus, but it's still kind of hanging on in the head, but it just doesn't heal. And if you put the long one down, you're sort of just planting your flagpole in a bigger hole, so maybe it holds it up a little better. But yeah, we fix them.
In India, are they doing more short nails or more long?
No, the problem is excessive bowing of the femur. So if you take, say, a synthes nail, a long nail, it would still come and hit the anterior cortex somewhere. So what we are now doing is take a midway through. So see where the nail is going to hit the anterior cortex. And so it's more of long nails in porodic fractures than short ones. Paul, your opinion?
I probably have a little lower threshold to replace than these guys do for two reasons. Number one, I do arthroplasty regularly, including revision arthroplasty, and also I'm actually the guy in our practice who does the cases where the nail cuts out. That's me, the guy who pulls the nail out and does a fluted modular tapered stem and converts that total hip. That's me. So I still don't do a lot of them though. I mean, I would say probably easily 98% I fix. The ones that I have replaced have been ones that have something going on in the neck that I'm worried about. So like I had a lady recently that had an intertroch, but she had this coronal split most of the way up the neck. Like that just did not look like it was gonna heal in my opinion. So I'm mostly a fixer, don't worry, but occasionally I'll do an arthroplasty.
Okay, so the days of coxofemoral bypass in intertrochanteric fracture are more or less over. The consensus is to fix them and fix them well. One last question I'm going to ask the entire panel is the use of cement. Now in India, it's being promoted more and more, the trauma SEM, and it's kind of promoted as a bailout option for severe comminution, for improper reduction, which is not a good thing. And, it's been sold as if you fix blade or a screw or whatever in that cement and then don't bother about the fracture, it will heal. So, your opinion on that? Christina?
Are you using polymethyl methacrylate cement or calcium phosphate?
No, the trauma SEM that comes, low viscosity cement. Yeah, PMMA.
So I've never done that. Sometimes I will use calcium cement on a revision. I've never used it on a primary that I can remember. And by primary, I mean like a primary intertroche fixation. I've never actually put the cement in there. But if I take out a screw or a blade that has failed or is in the wrong place that I'm revising, I will usually fill that hole with calcium cement. But that's really the only.
Okay. John?
Yeah, I don't use it at all. I want the fractures to, like, if I'm trying to get something to grow back together, then I want it to grow back together.
So even in a severely porotic, frail lady, you would not put primarily?
No, I think if you're going to try and get it to grow back together, get it to grow back together. And the cement is only going to make that not grow back together. If you're going to go for arthroplasty, then go for arthroplasty and cement, you know, a nail with a big ball on the end of it that looks a lot like a hip stem and just take care of that. Okay. You know, I think as a bailout, you know, I used to do a lot of modular stems. I liked doing them. You know, they're kind of a fun case, but I've learned that, you know, a long stem cemented hemi is a really straightforward, simple operation. You can cement a stem in distal to everything and then build off your stem if you need to. It's a very good bailout. But I think
not really it doesn't really affect the reduction because it just squirts out the tip. So you're just kind of cementing the blade, or not the blade, but the screw part into the head. The problem I have with it is, you know, most of the time I'm only using it on ones that other people have already done something to. And I don't know if when they put their screw in, if they drilled through the femoral head or that sort of stuff. So I'm always kind of nervous when you're squirting this stuff in that it's just going to extravasate into the joint and then you have a real problem. So if I do it really slowly with fluoro, and you can see the cement coming out. And I just kind of put enough that it's just around the head and maybe
About
catching some
3
bone.
cc or something.
Yeah.
2 or 3 cc.
Yeah, but really slowly so you can kind of see it come out and before it goes into the joint.
Okay.
Paul, are you using revision or using modular stems mostly?
So the question was if I use modular stems for arthroplasty, and the answer is actually I use them less often now than I used to. When I first started, it was kind of a safety net because obviously you can change the body. I much more commonly just do a monoblock stem now. But I don't have anything to add about cement in trauma. I'm the same as these guys.
And primarily for intertrochanteric fractures with porosis, are you using cement? Primary fracture, not revision?
No, I haven't done that yet. Just like they said, if I'm taking one out, I will put some calcium phosphate up there, but I haven't used it yet for primary case, although I think it's reasonable. Okay. Yeah.
Fine, thank you very much. So we move on to the next controversy, and that is next topic, that is controversies in ACL reconstruction by Professor Mandeep Dhillon.
Okay, thank you. I mean, ACL reconstruction is not a controversy. How we do it is actually some of the things which are topics for debate or could be controversies. And I'll bring up a few which we could see whether we can get any discussion out of it. You know, the rates of ACL reconstruction in the UK have increased 12 times in 20 years. It's probably the same in India, or maybe more, because more and more people with experience are doing ACL reconstructions. And so many ways, aspects of how we do the ACL have also evolved. So some have become controversial, some have become less controversial. So the debate, if any, comes up in about 6, 7, 8 topics. What to do in women, what to do in children, what kind of graft, how do we get the stability of the graft, what about the rehabilitation protocols, and should we be repairing them or can they regenerate also? So these are the things which I will bring up one by one over here. One of the hot topics which we've been talking about 20 years now, and this is the picture when I was in Sri Lanka working with the Sri Lankan spinners, is that people are now realizing that women are different. Their anatomy is different, their electrophysiological and hormonal issues are different. So probably because of a wider pelvis and bigger, more genu valgum, a smaller femoral notch, a longer mechanical response time, women in the equivalent type of sport will get more injuries than men. So women soccer players will get more injuries than men soccer players because of the changes over here. And there is also this concept of joint laxity, which is controversial because people talk about the integrity of connective tissue being dependent upon the hormones. So because with estrogen rises, relaxin rises also, and perimenopausal injuries could happen. So should you ask the ladies to not play certain sports when there is this time of the month kind of stuff? And there is a major controversy coming up about this. So now people realize that the injuries of the ACL in women are different from these chauvinistic guys called men. What really happens is, person to person, women have less muscle strength. They may be differently placed. They recruit their muscles differently when they land from a jump. And this is because of a different hamstring firing sequence. So, one of the controversial publications in the literature says that comparing exactly similar levels of game, women will have 8 times more injuries in basketball. That's a controversial statement out there. Women in soccer will have 6 times more injuries than men. It is because of the things which I have said, and most of them in ladies would be non-contact injuries. So there are so many things which have been developed, I won't go into the details, because now over here, an understanding and a method of prevention is being emphasized. What about children? When we get a ACL injury in a child, it's mostly an avulsion. This per se is easy to treat, and there's really no controversy because even in the older times when we used to treat them, you could fix them up now. But now people are starting to understand that maybe when the ACL is avulsed, there may be a concomitant stretching of that ACL, and even if you put it back, there could be some residual laxity. So in adolescent periods, people are saying that maybe we should even think of doing an ACL reconstruction, not putting these avulsions back over there. So this is because the ACL loading here is a low energy force, and the stretch will come up in an elite player later on in life. So the controversy in children is, should you avoid surgery? If you want to avoid surgery, when should you intervene? Should you intervene in non-compliant patients or those guys who have an ACL plus a meniscus injury? And this controversy comes around the 3 T's. Where do you place the tunnels? What tissues do you use? And what techniques do you use? So many years ago, almost 30 years ago, people started classifying the reconstructive methods into 3 types. The physial sparing, the physial completely transphysial, and the partial transphysial. So the grafts now, people are saying that we should be taking thinner grafts and we should be fixing them away from the physis. But then again, people have started using new techniques, new methods like the flip cutters, and where they put the graft holes only in the physis and they do not cross the plates. And that's what's been happening in many areas. So controversially, younger and younger children are being fixed with stronger and stronger grafts. Now the graft choices. Conventionally, we started with autografts, which were the hamstrings or the bone patellar. But the last 5 years, peroneal tendons have come into play. And being a foot surgeon, I am very sort of uncomfortable with going over this. Allografts in the West are very common, but in India they are not readily available. And synthetic ligaments, some have gone, some have come and gone, large failed, and so many other things like fiber tape and augments are over here. So the controversy between BPT and hamstrings still persists. Although the hamstrings have less post-op complications. The bone patellar tendon is better in high demand athletes. And this is shown in the literature, which showed that the BPT went up very significantly in the 1990s. And then it came down because the hamstrings went up very significantly in the early 2000s. But recently, in the last 5 years, bone patellar tendon is again, according to the publications, coming up over here. However, wherever they are used, especially in the US, and we'll get a comment from the AAOS faculty, allografts are very popular, despite the fact that they could have potential things like problems like infection, etc. They are not available in India, and we have a cost and availability problem over here. Recently, people have started talking about peroneal tendon grafts. I've been in debates about this peroneal tendon allografts, and if you look at the publications, it's only in the last 2 years in the PubMed that most of these publications come up. And the first publication which comes up is from my friend Kiran Acharya, who lives in Mangalore near Goa. This is the first publication. But there is no sufficient evidence which says that the peroneal tendon grafts are better or almost equal to other autografts. In fact, I know of some complications which have come up with peroneal tendon autograft. But still, I see in India, many surgeons are wanting to use the peroneal tendon as a graft. So if you look at it, the graft selection actually depends upon not the graft properties, but on the patient characteristics and expectations. One controversy which came out of the US was the double bundle concept. I don't know how many of you have used the double bundles, but it talked about 2 functional bundles, each having a unique function, and we tended to use 2 separate grafts, and Freddie Fu was the biggest proponent of doing all of this. But now we know that double bundle means double the trouble. It also means double the cost without getting too much advantage. And if you look at the trends in the published literature, since 2010 when the double bundle peaked, now in 2024, it is gradually phasing out. So this is the controversy which still many people talk about. A newer controversy or a hot topic is how do you place the tunnel? And the tunnel placement is in the femur, not in the tibia, because we started off when we started doing these ACLs with a 2-tunnel incision. That means 2 incision, one through this and one rear, where the exit in the femoral tunnel was done. But now most of us are changing to what is called as the transportal technique, not through the tibia, which is the transtibial technique. So this is because most people think that the directions of both tunnels should not be in a straight line. The pull would be different over here, they should be oblique, and therefore, although I've been doing the transtibial tunnel for a very long time, I still haven't had too many problems. It is thought that the vertical tunnel in the femur restores only AP stability, not so much the rotational stability. And that is why many surgeons have evolved to a transportal, where there is an oblique tunnel made through the anteromedial portal. And when you place the graft here, because this tunnel is shorter and there are so many things, you could get stability. But then, why there is the controversy is because there are so many downsides to it. It's shorter, the tunnel could blow out, it's difficult to put in a femoral reamer, you could impinge against the condyle. And then to look after this controversy, some companies have introduced flexible reamers which allow you to make different tunnel directions with different reamers. But still a controversial topic, and maybe we could discuss it if required. How about graft fixation? This is about the last bit of my talk. I've got another 4 minutes. This is 2 types. One is the distant fixation. We do it at the edges of the tunnels. And the second is the interference fit, which we do it at by using screws inside the tunnels. And they have evolved with so many fixation devices coming into play. And the most recent ones don't have so much controversy, are the biodegradable implants. We've had pins which give you the good stability. We've had screws, we've had button. But the key point here is you must have good initial stability so that you can get an accelerated rehab. And that's going to be my next stop. So for this, if you are using bone plugs, perhaps there's no controversy. Interference screw gives the best. If you are doing anything else, you can use any one of them. And most of these compounds are evolved over here. But one of the last things which I want to talk, which is controversial, is the rehabilitation methods. Many people still immobilize their ACLs. Many people tell them to start walking and bending on day one. And then there are many people who are somewhere in the middle. So the current protocols have become more aggressive, although they've evoked controversies also, but they are based on immediate motion and cryotherapy. And what people forget, that if you want a good result, there is no controversy on doing prehabilitation. Work on these knees before they come to you for surgery. Like Dr. Malhotra was saying, for elective TKRs and THRs, build up their bone mineral. So you should work on this. And the controversy again is about return to sport, with different protocols and different sports having different return to sport. I come back to the controversy I talked about earlier, which is female rehab. There are schools of thought which says that gender differences make rehab protocols also different, because women land differently after a jump. So we may need to be teaching them different muscle firing sequences so that they land well. They land on a flexed knee after an ACL reconstruction. This is most important for basketballers or maybe even badminton players. And then there are people talking about specific exercises to control valgus movement. So these are the things over here. So what's the future, guys? Maybe we won't be reconstructing ACLs, maybe we will be repairing ACLs, and this is by adding biological reconstructions to the ACL repair and reconstruction. So this is the last hot topic I'm going to talk about. There's this study which talked about 20 and 20 repairs versus reconstruction. Both groups had good outcomes, stability, patient outcomes, but the revision rate in primary repair was higher. That means it did not succeed as much over there. So can we enhance repair? This is where the controversy is coming up in 2024. And there are multiple factors which influence outcomes after repair. There may be a time when you get an ACL, you repair it on day one, forget about reconstruction. But the key point is, if you're looking at repair, do it early. If you wait for 2 weeks, the reduction of repair strength is 40%. You must augment the repair. And if we do it, the controversy is how. One of the things is an internal brace, which you can do it over there, or there is an experimental spring which is there, what people are talking about, that you could put it in there which sort of augments it till it heals. Or you can use orthobiologic substances or scaffolds to enhance the repair. And there are so many things available over there, like tissue engineering, engineered collagen scaffolds and PRP, stem cell, etc. So something like this could be the future. This is a case where they've done a fertilized anterior cruciate ligament reconstruction augmented with amnion, with bone marrow concentrate and a suture tape. This is what the big controversy is today. So folks, where do we stand today? Although ACL reconstruction is an established procedure, we have better fixation methods which are reducing some of the controversies. The graft positioning is being discussed because we need to have it more precise. And the controversy about double bundle is being resolved to some extent, although the die-hard double bundle guys will still do a double bundle. And there is no doubt that women get injured much more often. Their rehabilitation may be different, and repair of ACL with enhancement may be the future. Thank you so much for your time.
Thank you, Dillan sir. We will have a discussion on these 3 points which you stressed about. I will take the opinion of the esteemed faculty. So I'm going to ask you 3 questions, each one of you. First, as far as ACL is concerned, one is the timing of ACL reconstruction. Second, the choice of graft. And third, the choice of fixation. Starting with
Yeah, okay, let's see if I can remember those questions. And full disclosure, I don't do ACL reconstructions, but I know the folks in my group who do. So timing, they're going to wait about 6 weeks to make sure the swelling is down and the patient's knee range of motion is returned. They overwhelmingly use hamstring. They will use some allografts, but only in older patients. And young patients, it's going to be hamstring autograft. And then fixation, they're going to use a biologic interference screw on the tibia and an endo button on the femur.
Okay.
Yeah, I'm the same. I don't do any of these. Our sports guys do all of them. They do wait though, because I send them a fair amount of like the dislocations that they'll wait and rehab them, make sure their motion's back. They're using a mix of grafts. They're augmenting almost all of them now with the internal brace to see if that, and they're pretty convinced that that does something. They're trying to do some repairs too. They're doing a study on some of the repair and augmenting with the internal brace, but I don't know that they've reached any conclusion with that yet.
Sean?
Yeah, I mean, locally in Boston, we had some development work done on a system for primary repair of the tendon rather than replacement. And it's been FDA approved. It's now available on the market. I'm assuming you don't have it here. Sorry. There is a system that's available that our guys in Boston have been using in certain instances, typically in younger patients, adolescents for sure, but most patients under 30. One of the stipulations is that they have to be primarily repaired within 30 days. So in those situations, they're being more aggressive, and they are doing an actual primary repair of the tendon.
Primary repair.
And then they have a biological sleeve that they sew around it, which augments the repair. I think the FDA approved shows that it's effective, but jury's out as to whether it's going to be used long term. In our situation, it's quite expensive, and it runs about $4,500 for the piece that you sew around your repair.
Okay. Christina?
So full disclosure, I actually know nothing about the ACL. I haven't touched an ACL on purpose in 15 years. The only real connection I have is the multiligamentous knee dislocations that I take care of as a trauma person. And oftentimes I'll do, an acute repair on one of the other ligaments, and then the sports people at my institution will do ACL, PCL. But it's not uncommon for me to do the posterior lateral coronary acutely.
When would they do it? So you're handling a dislocation or a fracture with an ACL.
So when they do, what they often do is get them prehabbed first, right? So I think someone had mentioned a second ago, that's usually like 6 weeks or so. For some of my trauma patients, if they have 6 under injuries, then it's actually, 3 months before they can bend their knee enough that they want to have the ACL done. And usually for my sports guys, they'll want to make sure that all the other fractures are healed. They can weight bear, they can rehab, nothing got infected before they go ahead and start putting grafts in. So it's a little bit different. I think my practice is probably not a good example for... Yeah.
Dylan, sir, anything else you want to
No, I think they summarize exactly what I said. When should we be repairing, and the timing.
Right.
Sir, I have a question.
Yes.
Sir, one question. Sir, do you in case of you get a thin graft, supposing it's around 7 mm, so do you believe in augmenting it with a fiber tape?
That is one of the indications. I mean, it's rare to get it. You either got, instead of a four-strand graft, you got a 3-strand graft. Then you do it. But most of my practice is bone patellar tendon, so I am okay with that. But yes, if your graft is undersized, you have to augment it.
But sir, the fibroelastic properties of the graft and the fiber tape,
they are different.
They are different,
Yeah,
and
but
so
there is a creep in this. So that is what people I've seen in India, they don't do it. They don't stretch out the hamstring graft for a while. They prepare it and they put it. Whereas theoretically you're supposed to be that's why the tray is for. You're supposed to be stretching it, although it won't come out. Some creep will come into it. And then more of the load will come on the fiber tape than on the hamstring graft. But that's you're sort of managing situation when there's a problem. It's not the routine.
Yes, it's not the routine. Yes, that's right. Second question is about the internal bracing. Do you use it in your
Not
practice?
routinely. The problem is the cost. And although John said that they use it routinely in their high-end places, very small percentage of people who are high demand, like in high-level football, etc., people are putting in. But if you are thinking that your original graft is going to get strained, the strain will come on the internal brace.
Yeah.
I know of some people in India who using internal braces in all their cases.
Yes.
Doubles the cost.
Right.
Sir, you said there's some difference now that we come to know with male athlete and a female athlete. Any difference in the technique of ACL reconstruction in the two, or
Not really.
the
You have to
graft
be-
choice or fixation in it?
I don't know. The issue is that in females, there is a higher tendency for people to use the hamstrings because of the scar in the front. They don't want the ladies to have a scar right there in the front. That is one issue. Second is the notch is narrower. So you have to be careful in your reaming, etc., notch placement, and maybe a hamstring graft is more accommodating. If it impinges on the notch, you are in trouble anyway. So those are the things which people are doing. Distant fixation. Now the population in India had shifted to 90% hamstrings. We talked to the Indian Arthroscopy Society, and 10% were about bone patellar tendon, but it's now gone back to about 22-23% of BPT and little lesser in the hamstrings.
Okay.
Because we did a study in which we found that the hamstring actually was important for the knee stability to some extent. We also did a study proving that 60% of the hamstring regenerates. But what do we do when you want to be a coper? I asked the simple question. You want to be a coper, you tell them strengthen your hamstring, it will prevent the tibia from subluxating. Although it's the lateral tibia which is subluxating, not the medial one, and we are taking the medial hamstring. But still, hamstring is something which keeps the tibia back.
Okay. Thank you very much, sir. So we move on to the next and perhaps the most controversial topic today, and that's DVT prophylaxis. Dr. Samir Agarwal.
Yeah. In India, it is a controversial, and in the West, I don't think so. It is a controversial topic. So it was Virchow who identified in 1856 the three basic interacting factors responsible for this venous thromboembolism: circular stasis, endothelial injury, and hypercoagulable state. And pelvic gastral trauma or any complex trauma and its subsequent management tends to activate each of these three components of Virchow triad. Whenever there is a fracture, there is immobilization in pre and post-operative area. This is the difference. When you are doing arthroplasty, you are mobilizing the patient on the next day. But here you are immobilizing even post-operatively. Endothelial damage because of fractures and during manipulations, during surgery, you can injure the vessels, the indirect injury is there, and because these patients are polytrauma, there is chances that there is a hypercoagulable state. So there is a chances. And 20 to 25 of calf vein thrombi extend into popliteal, femoral, or pelvic vein causing proximal DVT. And half of 50% of these DVT will develop into pulmonary embolism. In Western population, there are lot of studies are there, and average deep vein thrombosis is 35 to 61%, proximal DVT is 25 to 35%, and risk of symptomatic, I'm not talking about asymptomatic pulmonary embolism, is 2 to 10%, and fatal is near about 2%. So we are more concerned about this 2%. We want to avoid this 2% so that we can save the life. Conflicting reports, 0 to 72%. They say it's a disease of Western countries, not Indian, not Asian patient. It is not common in Asian. So these are studies, some studies says incidence is 2.2%. Another studies by Dr. Jain from India, 1.9% proximal DVT, no cases of pulmonary embolism. Another case by Bagaria, DVT has a lower incidence in Indian patient as compared to the lower ethnic. So there's no need for giving prophylaxis. It is not cost effective in India. As opposed to this, there are few studies done in Japanese people. This is as common as Western population. Another study is done in Italy about Asian patients. They says definitely it is equal to Western countries. In India, this is the first study by Agarwala, but he has done with color Doppler 19.6% proximal DVT. Another study done by Lalit and Sharma in Indian Journal of Orthopedics, 50% of hip replacement and 60% of knee replacement patients without DVT prophylaxis will have DVT. Another study done in south of India says 28%. Strong case for prophylaxis. But all these studies are mostly in arthroplasties. There were conflicting opinions, which one to believe. There were few studies were done for the hip surgeries also, but there was no study which is dedicated to pelvic external trauma. So we did our first study in pelvic 10 years back, 56 patients with pelvic trauma who underwent open reduction internal fixation. The average age, they are young, 36 years old, 48 males, 8 females, conducted over 2 periods. All young patients and with all comorbidity and associated injuries were excluded from the studies. Only pelvic external trauma patients were taken up and all underwent investigation of 5th day plus minus 2 days. And what we have done is pulmonary angiography and indirect venography of bilateral lower limb and pelvic veins. We got the ethical clearance. We used 130 ml of contrast. And this protocol picks up every case of pulmonary embolism, uses the same contrast for venography and adds only 3 minutes to the study. We did the follow-up color Doppler study in all cases after 6 weeks in these 56 patients. And these were the results. You can see saddle type of embolus or popliteal vein. 16 cases out of 56 had a radiological confirmation of DVT. It means 28.6% patient of pelvic external person without prophylaxis developed DVT. But only in clinical, I say, is only can say that it is a clinical symptoms were there. 10 patients were asymptomatic. And we know that it is 2 to 10% pulmonary embolism. So if we miss this, we can lose one person out of these things. We published this in GOT and International Orthopedics. Then there comes a landmark paper from Chile, from Bristol. They have seen 103 patients, and they concluded that DVT was developed in 3% when prophylaxis was given within 24 hours, as compared to 22% when given after 24 hours. So this is only if you are given within 24 hours, then there is a benefit of DVT prophylaxis. Otherwise, it will be as equal without giving prophylaxis. But is it possible in India? Our patients come late to us. Mostly patient comes after 24 hours to trauma centers. Usually they are polytrauma with head injury, blood trauma chest, blood trauma abdomen, with relative contraindication prophylaxis. We can't give them. They are head injuries. Or color Doppler and compression ultrasound was not good. Most of the studies have done that, used that. We have done pulmonary. So, second study, we planned it. We divided into 3. Group A, where patient presenting early, within 24 hours, and we were able to start the prophylaxis within 24 hours, keeping that Stele paper in our mind that we have to give prophylaxis within first 24 hours. Group B, late initiation. They come to us late, or they were hemodynamically unstable. We made them stable, and then we started. So they were in group B. We also included all the patients which has a contraindication for chemical prophylaxis to see how much DVT is there. And these patients have associated open fractures of tibia like. So first we stabilize the fracture, put the fixator, and we put these group into group B, because we started prophylaxis after stabilization after 24 hours. 14 of our patients were in group B from this, which has open fractures of tibia. Just like blunt trauma chest, patient with mild hemothorax, post-ICD removal, got categorized under group B. Patient with multiple rib fractures, flail chest, major lung contusion or severe hemothorax, we were unable to give prophylaxis, so they were put in group C. Similarly, in blunt trauma abdomen, in case of hemopyridurium without solid organ, we put them in group B. With solid organ, we put them in group C. And 5 patients in our study presented with hemopyridurium, we started after 24 hours. Head injury, all the patients who are coming with head injury got the CT scan, and after 12 hours again CT scan was, and we observed another for 12 hours, so that there is no contraindication to start the prophylaxis, but they are started prophylaxis after 24 hours. And intracranial hemorrhages patient, we categorize in type C, where we were unable to give prophylaxis. And what prophylaxis we have given is deltaparin, 5,000 international unit once a day for 5 weeks. And mechanical prophylaxis and physiotherapy was started whenever possible in all cases. We have done venography on day 10 to 14 because it is hypothesized that maximum chances of having DVT is 10 to 14 post-injury day. And at 4 weeks and 8 weeks, we have done compression ultrasound like for follow-up cases. And we were able to see 171 patient of pelvic arch trauma patient in 1 year of a study. Group A was the smallest, 33 patient, where we are able to start prophylaxis within 24 hours. 76 patients were where we started the prophylaxis after 24 hours, and 62 patients where we are unable to start the prophylaxis. And when we see the result, in group A, where we started within 24 hours, 5 out of 33 means 15% incident was there when we are able to start within 24 hours. But to our surprise, in group B, where we started the prophylaxis, but after 24 hours, the incident was again similar, near about 10 out of 76, that was 13%. But the cases where we are unable to start, give any prophylaxis, chemoprophylaxis was 25%, and in our first study also it was 28.6. So without prophylaxis, we were convinced that it is near about 25% to 28%. But in group A and B, we found there's no signal difference between group A and B. Group C signaled high in comparison to group B and A. So incidence of DVT high in Indian patient, this controversy about whether we have incidence of DVT is there or not is now over. With our 3 studies in our PGI, we are convinced that chances of DVT is as high as in Western population. So our results were in contrast to Stele. We have done in 171, they have done in 103 patients. They have used color Doppler, we have used venography, that may be a difference. So we have also observed that there is no difference of venous thromboembolism in cases of sternum, pelvic fracture or combined fractures. All 3 have the same incident of fractures. And among the vestibular fracture, transverse and posterior wall fracture, you must remember that if you receive a transverse and posterior wall fracture, chances of DVT is more than other vestibular fractures. Associated spinal injuries, again, if you have a pelvic sternum fracture with associated spine injury, chances of DVT are more. Associated orthopedic injuries did not increase the risk of DVT. However, associated non-orthopedic injuries, again, chance of having a DVT is more, especially if a patient is having a blood trauma abdomen. Then you have to be very careful that chances of DVT are more. And if your injury severity score is more than 15, or chances of DVT is always again more, and there is no influence of sex, age, development of DVT, even the anesthesia, spinal anesthesia, general anesthesia, there is no difference in the incidence of DVT. This is very common. We delay our surgery sometimes 10 days. We have that analyzed that if you do surgery after 10 days, chances of DVT are again significantly high. When you operate within first 5 days or 5 to 10 days, chances are less. But if you operate after 10 days, chances are. So we conclude that administered DVT prophylaxis play a major role in contrast of not giving the prophylaxis. No difference between early and delayed prophylaxis. So what should be the treatment, prevention? Again, there is a controversy. What should we give? VT prophylaxis drugs has potential side effects. Those who are not giving, there are chances that it will lead to bleeding, it will lead to more complication, or if there is a pulmonary embolism, it is a life-threatening. So we have to make some balance. We have to think about the complications and the benefit of giving prophylaxis. What preventions we can do? Early mobilization, but in most of the pelvic acidum trauma, it is not possible. Avoiding hemoconcentration by maintaining adequate hydration, we do it in all the trauma patients. Physical or mechanical prophylaxis can be given, but which one? There are plenty are available, and chemical prophylaxis, which we should give. Mechanical prophylaxis, graduated compression stockings. These are the most common, most cheapest thing available with us. Pneumatic sequential compression devices, calf and foot muscles, and early mobilizations. So I ask the panelists, which one you will prefer?
As far as what we do for pelvis and acetabular trauma, we use Lovenox for 6 weeks for those patients. For all our other trauma patients, we typically transition them at discharge to aspirin. And we use mechanical compression for everybody while they're in the hospital.
Yeah, we're pretty similar. We do Lovenox for the pelvis and anything that we think might have a higher burden. Some of them will go home on Lovenox as well. If they go to a nursing home or rehab facility, we send them out on Lovenox. Some of the ones who go home on their own, a lot of times will just go on aspirin. A lot of the insurance companies around us won't pay for Lovenox as well, so then they have to go on aspirin. We'll do the pneumatic compression devices on everybody while they're in there. The problem we have with those is patient compliance, and they'll take them off. We just actually started an initiative in the hospital with the nurses that they go around and try to put them back on, because previously what would happen is they would take them off and the nurses would just document it, but they wouldn't say anything. Or they would sort of say, well, they're massage devices, they're squeezers, and I don't think the message was getting through to the patients, so we kind of changed the language that the nurses are telling them, this is to prevent you from having a clot, which could potentially kill you, and we're trying to see if that helps at all with getting the patients the message in. But we'll see.
So out of these mechanical, this study by JOT by Fisher, pneumatic leg compression devices significantly decreases VT incidence from 11 to 4% in their 300 patients. And this graded venous compression stockings have no role at present in trauma patient. Mechanical prophylaxis should be exceptionally useful when there is a contraindication for chemical prophylaxis. That is the choice number 1. So next chemical prophylaxis is mini-dose unfractionated heparin, subcutaneously twice. This is the cheapest drug available, heparin, but it has limited bioavailability, highly variable anticoagulant response. What is your take on whether you prefer this for DVT prophylaxis? Unfractionated.
Or I would ask the other way around, what do you prefer for hemoprophylaxis? Christina.
So I'll ask about each.
So we almost never use subcu heparin. I usually use, our center usually uses Lovenox, but I've worked in hospitals before that use fragments, so I actually don't, the specific agent doesn't matter to me, but a low molecular weight version of heparin I think is probably what I would choose for
so
inpatient
Lovenox
care.
is enoxaparin, is it?
Yeah.
Enoxaparin.
Yep.
So ACCP reports that low dose unfractionated heparin should not be used alone as prophylaxis in trauma patients. The other drug is low molecular weight heparin. So it is recommended as prophylactic modality of choice for major trauma patients. And East guidelines suggest level 2 evidence in pelvic fractures and those with injury severity score of more than 9, excluding those with the head injuries. So this is a drug of choice right now. I think so all panelists agree with this.
Yeah, our center is actually very aggressive. So about 2 years ago, the trauma team, the general surgery trauma team, launched an initiative essentially to hold DVT prophylaxis in nobody. So everybody gets their first dose, sometimes even in the trauma bay, if they're hemodynamically stable. And then we don't hold it for any surgery except if the orthopedic attending specifically requests it. So if we're doing a really big open pelvis thoracic type, then we have to request them to hold it even the morning of surgery. And then for neurosurgery, they repeat the head CT at 24 hours, and if there's no change in the head bleed, then they start Lovenox.
So, but you have to remember these absolute contraindication. Intracranial bleed, intraocular hemorrhage, incomplete spinal cord injuries with hematoma, constant uncontrolled bleeding, or uncorrected coagulopathy. You should not start this low molecular weight heparin in these cases. And retroperitoneal hematoma associated with pelvic fractures is not a contraindication if you are sure that it is not increasing in the size. Another drug, fondaparinux. Any experience about this drug?
So we only use fondaparinux in patients who cannot take low molecular weight heparin. And so if there's a concern about a heparin reaction, then we usually will go to fondaparinux, but I don't know of any of the centers I've worked in the US who use this as a primary agent.
So the best part is as effective as enoxaparin in pelvic and external fractures and not related to higher rate of bleeding. But you have to be very cautious when patient is of CKD. It has a long half-life, especially when there is a renal disease, so there may be accumulation, so chances of bleeding are there. The enoxaparin has a half-life of 4.5 and you have an antagonist, protamine. So in those cases where there is a renal issues, you should use fondaparin or enoxaparin. You have to be very warfarin, the cheapest drug available. Anybody using right now?
No.
No, yeah.
We do have some patients who are maintained on warfarin for their atrial fibrillation. And, we're pretty aggressive about, if their INR is less than 2.2, we'll just keep operating on them. And we're very aggressive about making sure they get their warfarin dose the night of surgery. If they have surgery, they get a dose of warfarin that same night. We've had some tragic situations where patients had their DVT prophylaxis held for surgery, and then their surgery got delayed, and then the next day they were planning on having surgery, and their surgery got delayed. So, I would, of all the things that we've talked about over the last couple of days, this is probably the most important, even though it's the least sexy and there's no x-rays. So this is a fantastic presentation, but I would say, make sure that you are not holding your DVT prophylaxis for surgery, right? Patients need their DVT prophylaxis and their surgery may get delayed, right? We've all seen the situation where something happens, the patient eats a bag of chips, whatever it is, and their surgery gets delayed. They need their DVT prophylaxis immediately, and they should get it throughout their hospital stay, and we shouldn't be holding it.
So when would you stop it prior to surgery and when would you restart it? Or you would not stop it at all?
We don't stop it. So our center, in the vast majority of cases, unless we specifically request, we do it the morning of and we do it in the PACU the night of, or the floor the night of. We don't hold it all.
Okay.
We do have, I'd be curious to see what everybody else on the panel is doing about apixaban. I don't know if you guys are using apixaban.
Sure. Yeah, I'll next.
Yeah, no, you clearly have
So,
strong opinions.
for this, you have to maintain the target of 2.5. So that is why people are not using it nowadays. Aspirin. What is your opinion about aspirin?
I love aspirin. Everybody gets aspirin. Like if you walk in the hospital front door to buy a donut, you should get aspirin.
When I got on my plane to come here, I got aspirin. That's how strongly I feel about aspirin.
Yeah, no, we don't care about them. That gives them something to do, right? Then they can put the scope in and find the bleeding. But yeah, I mean, big study out of the OTA. I'm not sure you're going to cover that, but big study looking at the effectiveness of 81 milligrams of aspirin twice a day versus enoxaparin with similar efficacy.
So still controversial in India. Not lot of studies are there. AAOS, they says in a low risk VT you can use this, but not for trauma patients. ACP guidelines, use of aspirin for VT prophylaxis in these patients is more effective as compared to placebo. But again, they suggest that you should go for low molecular weight heparin. NICE guidelines again do not suggest aspirin. SIGN guidelines says aspirin is not recommended as a sole pharmaceutical agent for VT prophylaxis. Nowadays, this direct oral anticoagulant, rivaroxaban. What is your opinion about this?
So this is a good agent which we use when the patient goes home. So because it's oral. Any thoughts on this?
Yeah, we use it when we have a patient that should be on Lovenox, but I don't think they're going to take the Lovenox when they go home. And so I give them an oral agent instead.
So unfortunately, these have not been studied for pelvic atrial fractures. So further studies are required. Similarly, dabigatran. It is as effective as low molecular weight heparin, can be associated with bleeding and wound issues. Again, most of the studies are done in arthroplasty. So these oral drugs are, but you have to remember, there are complications of these chemoprophylaxis. There may be hemorrhage, you have to take care. There may be wound hematoma, you have to see that. Infection, death, thrombocytopenia, and cost-benefit ratio has to be, because for us, giving enoxaparin for 5 weeks, 4 weeks is, again. IVC filters we have discussed yesterday. So if you can't give chemoprophylaxis or physical method, and you have to remember that if there is patient is high risk or patient has come to you with established DVT, this is the only option left with you. And remember that these endovascular devices do not prevent the development of DVT. They just interrupt the flow in IVC to prevent more significant sequelae of DVT, that is pulmonary embolism. So it's a life-saving device. And patient who receive this should be evaluated periodically for filter removal within the specific filter removal window, that is usually within 6 months. So you have to remove it. And remember, when there is no contraindication to giving chemoprophylaxis and patient has IVC filter, you should start these chemoprophylaxis in presence of IVC filter, because they do not eliminate the risk of PV, but they increase the risk of recurrent DVT and VT. So you have to start the DVT prophylaxis even in the presence of IVC filters. How long to continue?
We do it for about
chemoprophylaxis.
Yeah, we do for 4 weeks or so.
4 months?
Minimum 4 weeks.
4 weeks.
Minimum. And some of the people will do a little longer if they're not mobilizing, nursing homes, those sort of things.
So OTA consensus put that we should continue for 4 weeks duration of prophylaxis. And you can extend up to 35 days, because even after discharge, patient has a high risk of development of DVT than orthopedic group. And if unfortunately you have developed DVT, these are the treatment methodology. you can do anything. And these are the guidelines we have published. You can go through all the guidelines. Last year we have published it. So take-home message is low molecular weight heparin is the drug of choice. Ideally, one should combine mechanical and pharmacological both. It should be started within 24 hours if there is no contraindications. Duration minimum of 14 days, preferably should be 5 weeks. If there is a contraindication to drugs, pneumatic compression device with or without IVC filter should be considered. And for newer drugs, oral drugs, we need more studies to prove efficacy and safety of the profile. Thank you.
Thank you, Dr. Samir. I think we already have had a discussion.
Going to change all of the recommendations from like the chest, from East Trauma Society. I mean, that was a huge, huge multi-center trauma focused, including pelvic fracture treatment, even non-operative pelvic fracture treatment, and showed that aspirin is no worse than Lovenox. And so especially from a cost perspective, that's a huge difference in terms of cost for hospital systems if it doesn't make a difference. So I think that hasn't hit a lot of the recommendation, or a lot of the kind of group public recommendations yet, but I think it will. I think that trial was probably a game changer, even if it didn't change what every physician does day to day. I think it'll change the way aspirin is viewed as a viable prophylaxis.
And how long do you recommend using it?
What?
How long should it be given?
Oh, how long should we be doing the aspirin? I think it's the same 4 weeks, essentially.
4 weeks?
Yeah.
Or till the patient is mobilized well enough, maybe.
Yeah, I usually do 6 weeks for people who I don't let get up. If someone's on slide board transfers, for example, like no weight bearing on either leg, then I'll do 6 weeks, but 4 weeks otherwise.
Okay.
The only other comment I would make, we're all busy, right? We all see many patients on any given day, and it's easy for somebody to slip by you who has a history of DVT. And I've had a number of these over the years where, patient got a DVT, and then they say to me afterwards, like, yeah, I mean, last time I had this, they put me on Coumadin. And I think to myself, like, I completely missed the ball on those ones. Those patients are at particular risk. And it's easy to just focus on their trimalleolar ankle fracture and not talk to them about their medical history because we're broken bone guys. And I think, you really have an obligation to slow down a little bit and make sure that you're not treating patients who already have had a DVT and need probably 12 weeks of prophylaxis, right?
Okay.
They're just, not all patients are created the same, and some of them are hypercoagulable, and we really have an obligation to find those patients.
Right.
The other thing I would add is we get a fair amount of transfer people in, probably not the chronicity that you guys are seeing, but that have been sitting at another hospital for a few days before they come. And I would encourage, we scan most of them to see what's going on, because a lot of them will come in with a pre-existing DVT, but you're not really seeing them as, you just see them, they just got to you, you're operating on them the next day, so for you they're kind of fresh, but from the time of their injury they're not. And they've just been sitting around doing nothing at another hospital, and we found a fair amount of DVTs, on arrival.
Okay. Fine. So let's move on to the last talk of this entire conclave, and that's polytrauma.
And that's a real controversy, and it differs from place to place regarding the timing of fixation of the major fractures in polytrauma. There are no disclosures from my side. We'll try to understand how it differs from an isolated trauma, how polytrauma is different, analyze the different management options that we have for skeletal injuries in polytrauma, and try to get some guidelines or consensus regarding when to operate what from American people and experts as well as our Indian settings. First of all, let's understand what is polytrauma. Is it multiple fractured patient or is it something else? Remember why we are discussing this is because it's the commonest cause of mortality in India in less than 40 years, young adults. Forget the pediatric age group. In the young adults is the commonest cause of mortality. And that's the productive age group. And we all know, we always listen to this lethal triad of hypothermia, acidosis, and coagulopathy. We need to be taking care of this whenever we are dealing with polytrauma, and which makes it slightly different from the isolated fractures that we are dealing with usually. Evolution of definition, and that's what I was discussing. I had taken some of these talks 10 years back, 15 years back, and this was the definition which we used to discuss of two different organ injuries with at least one of them being a life-threatening one or multiple two long bone fractures. This was till 2006 to 8 when I think Pape gave this, and this was the definition which we all were trying to say with polytrauma. But now we have a proper consensus guideline regarding what constitutes a polytrauma, which was given by all these experts in Berlin definition, which is based on the abbreviated injury scores, which divides the body into multiple 9 places, and then you see which is the grading of the injury pattern from mild, moderate, severe, up to 6 grades. And along with this, it's given an objective sort of a criteria, so it doesn't differ from person to person. And at least some of these parameters has to be there, more than one or equal to them, which is hypotension, consciousness or major head injury should be there, less than 8, acidosis, coagulopathy, and an elderly age group. You can see the same lethal triad comes into play here, along with acidosis, along with the age pattern and the level of consciousness. So remember, whenever you have such a patient, don't just jump into the things, especially in our country. Maybe the things might be different than what the literature tells us. What we are dealing with is severe injuries out here. We all know this phenomena of the first hit, which is the injury, which leads to inflammatory response, and then it resolves in an isolated bony injury. Whereas, if it is a second hit, which is by a surgery or by infection, it leads to a hyper response, which leads to all the multiple problems that we deal with, especially in polytrauma situations. So the key orthopedic issues is, do you need to operate? When do you need to operate? And how much do you do? We all know regarding this, the early total care in 1980s, which was given when Pape came in 1993 with his damage control, that not all patients benefited from early total care, and some set deteriorated. And what were these sets? Were the critically severe injury patients with pulmonary contusions and femur fractures. Remember that polytrauma definition which I gave you? And try to correlate it with these things. And in fact, there was, if you look at this paper in 2011 in a JBJS, you see the authors, Larry Bone and Peter Giannidis, both of them early total, and this combined with DCO. And what they said was, both of them had a consensus that any patient who is hemodynamically unstable, has coagulation abnormalities, hypothermic, oxygenating poorly, should not undergo definitive intramedullary fixation until his general condition improves. He can have a stabilization, but a definitive fixation which similarly coincides with the polytrauma definition which we had in the Berlin definition regarding coagulation, hypothermia, and acidosis. So these three things are not going to go away from your polytrauma whenever you see them. Damage control orthopedics came up, may not be so relevant as it was 10, 15 years, but I still say in India it is very relevant, because what it does is stabilizes the anatomy so that the physiology improves of the patient. and you deal with the physiology. Once the physiology takes care and is improved, then you again come back to correct the anatomy. Prepare and avoid worsening of the second hit. We have all learned this hundreds of times. Peter Giannidis later on for the lessons which were there, and this gave it a slightly mild and moderated the use of damage control orthopedics. And what he said was that you can use it in unstable patients, but remember there are more trips to operation theaters and more longer ICU stay. That can happen. The cost of treatment may be theoretically greater. Most important thing is it should not be overprescribed. You should not use damage control orthopedics as an excuse of not operating on patients who can get better with early total care. Many a times it is used as an excuse to say that, let's put in a fixator, we'll see it later on. No. There will be a set of patients who require this, but majority of patients can get improved with ETC. And only 20% in their subsetting of polytrauma patients were suitable to be treated with damage control. So it has moderated the usage of damage control with some caution. Do not use it as an excuse. Remember, if you are using damage control, you are going in for a longer stay, longer ICU, more propensity for infections also, especially in Indian setting where the external fixators might be an issue. Now let's come to Indian scenario. And that's what I would like to highlight. You might read in n number of papers what is happening in the world and in US, but what is our pre-hospital care right now? When will the patient from the injury position come to the hospital? And as just Dr. Samir was saying, majority of his pelviacetabular 75 patients out of 170 came after 24 hours. So imagine that majority of patients come to us later. So there's a lack of pre-hospital care, and you cannot use it as a black and white that I'll use ETC or damage control for such patients. Because remember, in India, there is another hit which happens to the patient after the injury hit before he comes to our hospital because of the delays and lack of support system, which is known as the third hit or the second hit of the developing world. Why? Because the patients are under-resuscitated. Injury has already happened. But after that, in the initial 24 to 48 hours, they are not properly resuscitated. They are not properly splinted. The resources are not there. Their injuries have not been identified properly. And that has already causing the second hit to the patient before you can even intervene in them and do the surgery or so. And by the time you do the surgery, it is a third hit for the patient. So damage control becomes much more relevant in India for polytrauma situations when the patient comes to you in a delayed timing, as well as when the response and the immediate early, the golden, the platinum hours, the platinum minutes, the golden hours, and the silver day, all of them have been lost for the proper care of the patient. Remember, the peripheral centers may not be well equipped. Referral is with improper splintage, inadequate resuscitations, and more predisposed to complications. In such cases for us, DCO becomes, I would say, a necessity rather than doing an early total care, because now you are giving the third hit to the patient by doing a very aggressive surgery in an under-resuscitated patient. So always consider the second hit and the third hit phenomena when you are dealing with patients in India. When the patient is not coming within 10 minutes or 1 hour to you, 24. We are not talking in minutes, we are talking in days and sometimes weeks when these patients come to us. So remember that you need to have various perspectives regarding how the patient is coming to you. So let's come to the basics of Indian setting. These are the patients who will be a candidate for damage control in India. Might be different in US settings. Multiple injured patients having an ISS of more than 40, physiologically unstable, severe chest injury, severe traumatic brain injuries, and many a times in mass casualty situations, like in our hospital, you have 40 patients coming together with the building collapse, and then you need to manage them with damage control. This is a small audit which we did for our own ICU in a level 1 trauma center, and which showed you in 6 months, the 40 polytrauma cases were there with 30 cases of orthopedic injuries. 17 had shattered femurs. Only 6 patients we were able to give ETC or early total care, while 11 patients were managed with damage control. Why? Because they already had some symptoms or some problems by the time they had presented to us. And if you look at that, and how did we evaluate? ABGs, lactate levels, coagulums, thromboelastograms, INRs, chest x-rays. Physiological restrictions, 11 patients, and 9 out of them were referred with an average 2 days delay to us. And that's what leads you to take care of damage control rather than jump into doing a surgery saying that we need to fix the nail, we need to fix the femur first. Later on, the definitive fixations, 2 mortalities were overall. Just giving you an example and scenario of how it happens. 23-year-old male, RTA 1 day back, suffered blunt trauma abdomen, bilateral femur, bilateral tibial shafts. Comes to us late in shock. His BP is still not there, needed intubation for mechanical ventilation. ABG shows a lactate of 5.8, base excess of 6 minus 6.18. Resuscitative measures not responding. So what we had to do, went in for the exploratory lab where we found that he had some perforations, not us, our surgical teams, for which some procedures had to be done. And at that time, we had to do a damage control, and subsequently, the definitive fixation had to be done once his general condition improved and the lactate levels stabilized, and then you could go in and do the definitive fixation with the nails, the way it was done. So, remember, surgeon's discretion and the hospital setting where you work might be the reason how you are going to manage which fracture when in India. You need to understand the resource availability. What is possible in a level 1 premier trauma center may not be feasible in level 2 and level 3 centers in India, which we all people who are sitting here need to analyze and think where they are working and what facilities they can provide. Early appropriate care is the thing which has come up, which says that you base the decision based on the response of physiology of the patient. And what you do is femur and all the major fractures are fixed once the lactate levels stabilize. These are the ways by which you can do that. When to fix it, I'll again come back to that after giving you this. Evaluate a trauma team. A team needs to measure. Polytrauma is not an orthopedic game. It is an entire team who deals with trauma. Shock, acidosis, coagulopathy needs to be taken. If the patient is responding to resuscitation, you can do early total care. Make sure that pH, coagulation, and lactate levels are being stabilized. What do you aim for? Platelets above 75, PTs less than 2 seconds, INR 1.5, fibrinogens of this. Lactate becomes the most common parameter by which you measure when the skeletal fixations can be done in a polytrauma situation. If one thing which you require in your hospital or in your emergency department, you need an ABG or a lactate level. And then you can decide whether this femur needs to be fixed with the nailing or you need to go in for damage, because it is going to tell you how the cellular perfusion of that entire body is happening and how much well he has been resuscitated. So this paper shows that if it is more than 4, the mortality increases tremendously as compared to less than 4, and we take 4 as a cutoff for us, and we manage all the polytrauma patients based on their lactate levels, usually less than 4 or above, and decide accordingly. If it is more than 4, that means that acidosis is there. You may have to go in for a damage control. If it is less than 4, you can go in for your total care early. That's what I would say. Most widely used parameter in Indian settings in our hospital will be lactate levels of less than 4. Coming to the anatomical location, axial and femur need to be prioritized first. I'll just take 2 minutes, sir. Traumatic brain, chest injury, and major abdominal. These are the 4 things which we need to ensure. When to operate what. When you have a traumatic brain injury, remember there's a disruption of blood-brain barrier. It can have secondary insults, the brain leading to seizure, which may worsen the edema. So in a severe traumatic brain injury, which means less than 8, severe is GCS less than 8, you can delay it providing the parameters are being taken care of. Chest injury, you need to look at the rib fractures and lung contusions. There are scoring for that. And based on that scoring, you can decide whether this fixation can be a definitive or it needs to be a damage control for chest injuries, which includes the acute lung injuries, contusions, and the rib fractures, the flail chests, and so on. Coming to abdominal injuries, remember that there is an abdominal compartments and necrosis, which is also leading to increased lactate levels, especially in our settings where people have usually blunt trauma abdomens. So you usually can do it when they are operating, provided that your lactate levels remain fine, and you can get away by doing your fixations in blunt trauma abdomen, mostly as compared to a brain injury and a chest injury. So finally, I would say, multiple lower extremity diaphyseal fractures, fix the hip and the femurs first, followed by other injuries of the lower extremity, maintaining your lactate levels if they are less than 4. Borderline patients may avoid multiple simultaneous surgeries, follow a stage protocol. Priority of fixation is femur first, and then the lower extremity, other fractures, and upper extremity. That's how you go and manage. Don't forget the third hit phenomena, which is very common in our Indian setting. Thank you.
Any questions to Dr. Trikha on this?
Sir, as you said, lactate level is the main indicator. Suppose a lactate level is greater than 4. How do you know that it will correct, whether it will correct in 1 day, 2 days, or it will take very long to correct, so that you need to do a damage control, or you can wait for 2 days and do a definite surgery?
Right. So you will have an initial lactate levels when the patient is in emergency department. What is lactate level? It is showing you acidosis of the patient. The cellular acidosis and the breakdown which is happening comes out as lactic acid and shows it us. So it is an hypoperfusion at the cellular level. So you are trying to resuscitate the patient now. You are trying to make sure that the bleeding is not happening anywhere, and at the same time resuscitation is being done. And you then repeat this lactate level to ensure whether it is in an increasing level or it is going down. If the perfusion is improving at the cellular level, this is the most sensitive marker available right now in our setting. Previously, we used to look at the urinary outputs and the urine outputs as a marker. But now with this, we can know early if our perfusion and resuscitation is going in the right direction, and if after 1 or 2 hours of 3, normally we take it to 3 to 4 hours, and if we are able to improve his lactate levels and bring it down, this means the patient is improving and he is on the good path rather than being on a borderline or a transient responder.
You need to do lactate levels very frequently.
Yeah, you need to do them, because that's how you measure the blood pressure frequently. That's how you measure the lactate levels also.
It's not just the lactate level. I mean, don't get that message wrong. The resuscitation endpoints are hemodynamic.
Various.
So you cannot ignore the blood pressure, the blood gases. Along with that, an increasing lactate level, the reducing lactate levels are...
The lactate level is telling you whether to go and intervene in that sites. And
Yeah,
the
I mean,
overall resuscitation is happening side by side.
ETC and DCO is not just based on one level. It is an overall assessment of the patient. Any inputs on this by the faculty?
Can I make a comment? It's relevant to the same thing. So one thing is, you said your patient comes after 48 hours. So if you standard any literature after 48 hours, lactate has got no value. So all the lactate has got value is in the first 48 hours of the injury. Even the hither valier, everyone states that once you cross it, so in the Indian scenario, what sir rightly mentioned is the third hit. So what you are reading in literature, you cannot apply here. So here, for you, a 48-hour afterwards, a patient presenting with a higher lactate, it's a straightforward DCO in my practice. The thing, so exactly, the Americans, for them, they have gone through the whole of pendulum. Their resuscitation protocols have improved. They began with early total care, then the damage control orthopedics came, and then Hither Valier and their team, what they saw was how can we bring those subset of patients who were getting unnecessarily DCO to get ETC again back. But if you see, again, the combined paper from Larry Bone and Peter Giannoudis, even Larry Bone, Hither Valier, Pape, their whole concept was always the same. They knew what is a stable patient and what is an unstable patient. It's only the papers which came out, but if you put them together and discuss with them, they know to pick up an unstable patient and a stable patient. If it's a stable patient, go ahead with early total care. It's that unstable patient which is always DCO. Then came the concept of borderline, and Hither Valier's work was how we can shift the borderline patient to a stable patient. And again, the window, the timing is 36 hours. That's based on a network AI model where they came to an hour of 36 hours. But the question is, here in Indian population, these studies we cannot replicate until unless you have a level 1 trauma center with a team, with a patient presenting immediately, and you have the resuscitative efforts to cut it down, then we can talk about all of them.
One question I want to ask you, how commonly do you see fat embolism syndrome with long bone fractures, and how do you handle it?
I don't see it that often. I've seen it a couple times in the 10 years, but I would say it's relatively rare. Yeah.
Yeah, it's pretty rare with us. We did have one maybe, it was probably about a month and a half ago now, that the patient actually did very poorly afterwards. And it was just kind of out of the blue. It was kind of a weird case. We just did medical management.
Yeah, I mean, it's one of those things we see. It's one of those things we see infrequently enough that we don't know how to handle it when we do see it. And those patients will very rapidly decompensate. You know, part of the problem that they have is that they can't flow through their lungs, right? So they very rapidly wind up with right heart failure. And then they really do poorly. And if you have a patient with severe fat emboli syndrome, what they really need is to be on bypass, right? So that you can.
Or one thing which I like.
That's a problem, you know.
So I think they all have fat emboli, right? I think we all have to remember everybody who has a fracture has fat embolism, but do they have the actual syndrome or whatever the immune response or biochemical response to the fat embolism that makes them very sick? I think that's something that we poorly understand. And in my experience, it either happens to people who have really bad underlying pulmonary issues. You know, they have obstructive sleep apnea, they have some COPD, they have some other things going on in their lungs at baseline that make them predisposed. Or I also see it, and I don't understand this necessarily, I see it in really healthy 19-year-old athletic males. They will just drop after you nail both of their femurs in one day. So I am very hesitant to nail both femurs in one day. It has to be, I have to really kind of check in halfway through and be like, this person looks great. Anesthesia says they look great. I really hesitate to put bilateral femoral nails in this one patient in the same day for that reason.
Can I ask you a
Vivek,
question?
we see it quite
often.
Often, the fat
Yeah.
embolism syndrome. It's time we
No, the
evolved
thing-
into some proper protocols of managing. So I want to ask you, if you have a bilateral femur with a chest injury, would you,
Yeah,
and the patient is stable, would you do an ETC?
Yeah, I'll just try to continue further by saying that besides the fat part and the embolus part, it's an under-resuscitation which also plays a major role. And that's why you are not seeing it so commonly in your country, where the pre-hospital care is giving you that resuscitation right in the ambulance.
Okay.
In our hospital, the problem for the majority of people is isolated femur shaft fracture, they nail it, and he goes into ARDS.
Yes.
Remember this is the most common challenging medico-legal problem for you. A isolated femur shaft comes to you in a young patient, you ream it, nail it, and he goes into chest problems, and then he's intubated, and then you are in trouble what to do and why. It happened. That's purely because of under-resuscitation, the cellular, and that's where your lactate level comes into play. It's not when your entire parameters are falling down that you are going to do lactate. But in a young patient who is looking physiologically normal to you with his BP well maintained, pulse rate good, urinary output good, but his lactate is more than 5 and 6, that means he's under-resuscitated, he is having acidosis, which leads to the ARDS which we are having. And that's the reason in bilateral femurs that we usually will be having such, because most of the patients are young, physiologically they are able to maintain their homeostasis to a very great extent, because it's around 1 to 1.5 liters of blood. That's the one thing they're losing. In my setting, when a bilateral femur comes, it's a more bigger emergency for me than any supracondylar femur or humerus or for a child or anything. It is taken as a vascular surgery for us. We take him straight away to the OR, especially in my unit. We ensure that anesthetists are, primed regarding the usage and early fixation for them with the resuscitation. We take them one at a time. We start with one fixation, see the intraoperative assessment of the patient, whether his acidosis level is increasing or not after the reaming. If no, we go and do the nailings bilaterally, same sitting. If his deterioration is intraoperatively there, dynamic changing which was there, based on that dynamic analysis, we might go in for a fixator for one and the nailing. But our aim is to do the nailing right in the initial time if his physiological status allows us.
I think we should follow the same thing about bilateral tibias as well, because it's common in young tibias even.
Yes.
And I have had some really symptomatic pulmonary embolism in young obese unilateral tibias also. So it's not uncommon in tibias, and it's not uncommon in open tibias as well. So
Do you have access to ECMO or no?
Yes.
ECMO, yeah. So, so for patients who do have severe acute young patients with severe acute fat emboli syndrome, VA ECMO can be life-saving for them.
Very few centers have ECMO.
Yeah. If you have a patient that you think has severe fat emboli syndrome, get a TEE on them. Just get a transthoracic echo.
Okay.
And look and see whether they have evidence of right heart strain. And if they do, those patients you have to really be very, very careful with them. So, I would say if you have patients you think have fat emboli syndrome, get a transthoracic echo and make sure they don't have right heart strain. Because that can they can decline extremely rapidly.
Yeah, we do that. In fact, Professor Malhotra is here. He did a study on transesophageal echo as well for the arthroplasty. And similarly, we are doing it right now regarding the nailing part also, of understanding where and how it goes into the fat embolism.
Malhotra sir, any guidelines from your end?
No, his echo, he's the expert in the transesophageal.
No, bilateral femurs, bilateral tibias, any protocols, any guidelines?
So I think generally you would not like to harm a patient further by operating. So take a very guided approach. We have done 1 joint, 2 joints, 3 joints, and 4 joints in the same sitting, always with the condition that the anesthetist tells us whether it is safe to go ahead or not. You need to fix both the femur, definitely, and I think the study which is now being done, where we are going to do transesophageal echocardiography by Vivek's group now in AIMS, and I think that is give a good guidance to what exactly is happening. We did that during knee replacement to see what happens when you open the canal, so whether there's a shower, and we could actually show that there was a shower of emboli in the lungs, but fortunately did not correlate with any clinical deterioration of markers. But I think a good correlation between what is happening into the cardiac chambers in terms of embolic showers and its correlation with what is happening to the parameters. So that is going to actually guide, and I think it will be a good way to establish the guidelines for how many surgeries you can go for in one sitting, keeping a balance between the safety and the long-term benefit to the patient.
Okay. Any other message, Vivek?
Just remember that many a times when the patient hemodynamically, polytrauma patient, is unstable, we all are taking care of him. But the problem is happening in those cases which appear to be hemodynamically stable.
So-called stable.
Stable, the borderlines. And when you take them into OR to do our surgeries, saying that it is our orthopedic, we want to nail, then the problem starts. And once he is inside, medico-legal issues are a huge issue when a patient who is talking, walking, not walking, but talking sensibly goes into the OR and comes out intubated into the ICU with cerebral embolus and the other things. That becomes a huge issue. So make sure that we have those parameters.
So what investigations you recommend in a single fracture femur before surgery?
Just evaluation. We are all doing urine output we were all using urine output as our indicator of whether the perfusion is happening properly in the kidneys, 30 ml per hour and stuff. The same thing has now gone much higher. The mobiles have changed, much more become advanced. Get in the ABGs, take the base excess, take your other parameters like lactates. Make sure that you are having a comprehensive evaluation of the cellular perfusion in the body, rather than just looking at the X-ray and trying to nail it as early as possible. Because remember, their situation is different from ours. Our patient comes to us after 6 to 12 hours, 24 hours, sometimes at home, sometimes in a small hospital where he has not got any even IV fluids till that time. And its own physiological milieu that is protecting him till that time. So we need to understand that as well.
Thank you, Dr. Vivek. I think we have had a wonderful discussion on all these topics. I heartily thank our guest faculty from the United States for their excellent contribution to this course, and so also our Indian faculty who has come from all across the country. And I think all of you had a great time here. I hand over to Dr. Dhillon for Tarun for valedictory. Thank you.
So thanks, Dr. Chetan Pradhan, for very nicely moderating this controversies in orthopedic topic. With this, we will be ending our Trauma Conclave 10th edition. Lot of work, lot of intensive labor has gone in organizing this event. For that, I would like to thank, first of all, our program director, Mandip Dhillon. Thanks, sir, for all the efforts you have taken to make this program a big success. Secondly, I will like to thank all the faculties, speakers and chairperson who have been involved in this program for their contribution. I would like to thank our sponsors, ALKEM Laboratories, for their constant support in terms of bringing this program. I would like to thank my team for helping me in creating the agenda, organizing and mobilizing all the key opinion leaders and getting this program. I would like to thank the hotel staff and all the technical teams who are present here. So thank you, all of you. Now, we would like to felicitate all our faculty. I will begin with calling Mr. Rahul Chaudhary on the stage. He is the BU head for ALKEM. He will be facilitating first Dr. Gaurash Vargaonkar. He is an orthopedic surgeon and a GOA secretary. Dr. Gaurash, please can you come on the stage?
out and then we'll discuss.